Good morning, everybody. Welcome to this morning's public meeting of the Humber and North Yorkshire Integrated Care Board. Just to start, today's our first meeting where we have invited interested members of the public to join us in the room. So thank you for everybody who has indicated that they want to be with us. If you are in the room, just to remember, this room is incredibly sensitive in terms of microphones, so it will pick up anything you say anywhere in this room, and it may be recorded in the minutes. So we might just need to be mindful of that as we kind of go forward. We've also got people potentially joining us online as well, so thank you for your interest in the board. I suppose, just before we start, just to kind of acknowledge, I suppose, for my own benefit, that this is my first meeting as the substantive chair of the Integrated Care Board. I'm really pleased to have the opportunity to continue in this role and support the organisation and the board through a period of kind of significant change. And I suppose, reflecting on the past few months, I think, we need to spend some time thinking about the progress we have made as a board. And I think I want to encourage the ICB to continue to be bold and brave in how we approach the future, but also for this board to continue to be curious and challenging, because actually change only happens when we feel uncomfortable. And if we tread on toes, somebody has to move their foot. So I kind of think this board is exactly where it needs to be. I think the agenda today probably covers what we need to cover in terms of some reflection of where we are now and the opportunity we have to kind of make a difference there. Kind of reflects where we're heading in terms of kind of transformation and transition, but also I really welcome the opportunity you have with our colleagues from Catterick to kind of really share some of the good news, things that I think we need to be proud of. And I kind of wrote to staff at the end of last week after my appointment, and I said to staff last week that we spend a lot of time in rooms like this talking about things we haven't done and targets that we haven't met. And that stuff is important. But actually what we need to create the space for is to kind of be really grateful for the difference we make every single day, in terms of the ICB, but all of our providers as well. So I think there's something about taking opportunity at a difficult time to celebrate achievement, because we are doing some fantastic stuff in this ICB, and this is an opportunity for the ICB to shine. So just moving on in terms of apologies for absence. So apologies today, we've got Amanda Bloor, Karina Ellis, Nigel Wells, Tracy Meyerhoff, Merlin Joseph, and Victoria Lawrence. So just to cover off the complicated bit for the minutes, Michelle. We've got Jane acting as Deputy Chief Executive at the moment. In terms of corporate affairs, I think corporate affairs are dialing in just to keep an eye on us that we are doing things as we should. Dr. Crick, you're here in place of Nigel Wells. And Alison, I think you're covering not only local authority chief exec, but also adult social care as well. Feels like old times. Yes. It does indeed. Okay, thanks very much. And as we go through, it's quite a tight agenda. So there are some items on the agenda which we will cover in part A of the meeting, the public meeting, but also part B of the meeting as well. So I think for those people who are presenting in both, and I'm looking particularly at Des and at Sean, I think part one is to do the headlines, and part two is where we can have the detailed conversation around some of the stuff that you're telling us, and that will allow us to kind of manage time. And we do have a number of people kind of joining us to do presentations as well. So we will, as far as possible, and it's a reminder for me to stick to the time. So you have in your pack the register of interest for board members. Just a reminder from where we were last time, if you do have any changes in interest, you need to kind of let us know. But they are the interests declared at the moment, and that's here for transparency. Are there any interests that anybody particularly needs to declare in respect of part A of this meeting? Jane.
I think there's a number of us that will have interest when we talk about the
transition work.
Yeah.
So the transition work, I think there is a financial interest for anybody who is employed by the ICB or connected to the ICB as the item, but actually when they're not going to require people to leave the room or to not contribute to that. But I think that interest does need to kind of be declared. If any other interests kind of appear during the meeting, just kind of let us know and we'll work out how to manage that. And then also what you will have for the first time at board, and I know this goes to audit Stuart, is the declarations of gifts and hospitality, just so the board has sight of the gifts and hospitality that'll happen, and it will still report into audit, but we'll flag things via audit, but also I think just for the board it should be here as well. And we're going to work on the assumption that you've read the papers that we have sent you, and that you've come armed with questions for the rest of this meeting. So If we go on to minutes of the previous meeting, so the meeting that we held in public on the 9th of July, I'm going to go through, first of all, for corrections and accuracy, then we'll pick up mass arising in the action list. So pages 1, 2 and 3, 4 and 5, 6 and 7, 8 and 9, 10 and 11, 12 and 13, 14 and 15, 16 and 17, 18 and 19. So people are happy for those to be a true and accurate record of the last meeting? Thank you. So if we go on to the matters arising from the previous meeting, which is the action list, if we go through them. So the first ones were around the board assurance framework, and I'll look to you, Jane, in terms of covering governance at the moment. So we talked about removing the old risks and adding in new risks, particularly relating to fund operations. That happened. That's happened. We have included new risk around ICB transitions. That's happened as well. We're looking at the BAF as part of the agenda. Michelle, we asked you and the quality committee to review the risk for quality, and I think that's been done, hasn't it?
And that's in the papers, the discussion later.
Superb. And that we are planning to do a development session, aren't we, Jane, around risk in the board assurance framework at some point in the future. That's on the forward plan.
Yeah.
So I think all of those items can then be closed. Thank you for doing those. And there's a couple relating to Green Plan. So Teresa reminded me, Green Plan was something that wasn't going to be ours in the
future and is now likely to remain.
Ours.
Yes.
So we probably need to do a bit of work around just working out where the Green Plan kind of sits organisationally. And I know we've talked here about the reporting in through audit committee, but I think the Green Plan, we probably have an opportunity to do the wider partnership to think about where the Green Plan kind of sits. So we might just want to just confirm those arrangements around Green Plan. It was relatively clear a month ago, but it's probably less so now. Okay, I think they were all of the matters arising, unless we've missed anything. So we can close down most of those. So there is no any other business that anybody's told me about. In terms of questions from members of the public, we did have a question submitted outside the timescales for us to respond in the meeting, but I'm going to read out the question and my proposal as to how we move forward with the question. So the question received, it was received yesterday, and I think it's gone to you, Des, for a response, and we'll respond, I think, within 10 days to the person asking the question, but also publish this on the website. The question is a couple of quotes from the 10-year health plan, which are relating to the bit in the 10-year health plan that talks about expecting hospitals to do more as anchor institutions to support wider societal and economic goals, and a question that is around the NHS supply chain framework. And the specific question is what savings have the ICB and Trust identified using the NHS supply chain, and what actions have the ICB taken to ensure the NHS supply chain is the preferred procurement method to ensure best value spend and recurrent in-year savings? So it's to acknowledge receipt of the question, and we will do the response within 10 days. Thanks very much. Thank you. So we're going to move on to board assurance framework. So I was just going to, that has been shared in the pack kind of for people. All of the changes that we talked about previously around the board assurance framework, I think we have included within this version that is in front of you today. In terms of what we're being told, do you want to, am I looking at you, Jane, in terms of just taking us through this?
I'll just introduce, and then, as Michelle said, the quality one you'll pick up, and any questions on the finance one, Des will be able to pick up. So we've updated the BAF based on the conversation that we had at the board in July 25. So you'll see that in the main BAF, but there's two main areas for attention for us today. One is the major update to risk A1, which was revised by the quality committee. Mark and Michelle, you may want to discuss that. And then we've also got the Finance, Performance and Contracting Committee have submitted a new risk, which is B4. Both of those are for consideration and inclusion in our BAF today for us to discuss.
Super. Should we take A1 first, Michelle?
Thanks, and Mark might want to chip in.
Yeah.
So we took an action to review this area of the BAF, and we had a really in-depth and thorough conversation, I think, to be fair, at Quality Committee, and put a proposal forward where we are requesting that the words around the strategic intent are tweaked to make it really clear, and I'll come back to that in 1 second. And then we've tidied up all the mitigations. Some of them are out of date, some of them are very new, particularly around how our governance is supporting quality, things like SOAG and SILOG for patient safety. And we believe, therefore, that the mitigations in place are really quite strong, and our board advisors who are on the Quality Committee said that they thought they were strong, and so that the start-off score should not be what it was and should be 16, and then post-mitigation should be 12. So we're asking for the support for that. In terms of the wording, the original wording, I think, was in part the reason why people couldn't align the mitigating action gaps, because what it was suggesting is that the ICB quite rightly had a responsibility for oversight, early warning, all the governance around that. But it didn't have responsibility for making the improvements. That's the provider's responsibility. And so the wording was a little bit mixed up together. So we're suggesting a change to the wording as well to just make it clear about what our responsibilities are.
Thank you, Mark.
And just to, I think, emphasise the discussion that we had at Quality Committee was very much around ensuring that our absolute focus is on delivering excellent quality for our service users and patients. And the debate was, it was a good debate about this, and I think it's the right decision, and I would commend it to the board.
Thank you, Stuart.
When I read the performance report on things like waiting lists and cancer referral and so on and so forth, it doesn't feel like we're in an improving quality situation. How do I reconcile that data with this lower risk?
So I think it isn't that the risk has been reduced from what it was before. The risk is now what we believe to be accurate, whereas before it wasn't accurate. There's that first. It's not reduced the risk out there. So that's the first thing. The second is that we obviously go to where the data provides us some information, and it's a very small snapshot of all what goes on for quality, safety and patient experience. And so you are drawn, because we have to the performance data, and we monitor it in a very succinct way. But in the complete oversight of quality, which is led by the Exec Director of Nursing and Quality in particular, is much more broad church than that, and looks at all of the arrangements for quality.
So is the performance data improving? Is that why we think that?
When we come to Sean's section,
Just so
there are some elements.
So I think what's being said is not that the performance data is improving, excuse me, but the wording of the risk and therefore the score associated with that risk better reflects what our actual responsibilities are.
At this point, Mark.
Yeah, and I think the other thing Stuart raises a really valid point. The performance data, which is looked at in other committees, I think I would just emphasise as well. And to pick up Michelle's point, is not the overall picture of quality that we look at. And therefore, whilst it is an indicator to certain aspects of that, there is a broader piece around patient care. The way that we are interacting with our service users, etc., which is not just that. And so that's why we've taken this approach. But I think Stuart raises valid.
It's really helpful. I'll come back to that in summing up, because I think we probably capture that somewhere else. Michelle.
Yeah, that to Michelle's is really difficult.
It is.
Doing the risk assessment to start off with. Morning, everybody. I actually thought it was worded quite well, really, given the complexities of what we're trying to do. So I think sometimes when you look at it, it does appear that things are getting better, but I think it's worded right for what we said at the last board meeting. I think second board, the quality impact assessments, I think it will fluctuate and go up and down as the system goes up and down. But I think if you read the gaps, it makes more sense about how it's been scored, to be honest. And I think what we need to do as a board is keep an eye on not just that particular risk, but all the gaps to see if they're shortening or widening, because that will affect the risk. So I thought it was quite well structured. The only thing I would say, somewhere in the context, we need to have more emphasis on provider oversight framework as well. I think they give you a really good position on not just patient safety and quality, but the performance piece. And obviously, I know that's come out since you've done this, but I think it will be featured now to maybe just have a review and see where we can insert it in.
I think that's right. Simon.
It picks up on what Elder Michelle just said as well, actually, which is that, I mean, I think this is a sensible proposal to change this, and I accept the reasoning behind the change. But actually, I think a future board development session would be really helpful to understand if there's sort of changes in the landscape with regards to ICB responsibilities, provider responsibilities around quality assurance, but also to understand the landscape of quality improvement that goes on within our trusts, and to understand in detail the levers that a future ICB will or won't have with regards to impacting on quality, because it can sometimes feel like we're looking at this stuff and we've got all these mechanisms in place, but actually, are we assured that things are changing, and what can we or can't we do about it compared to the provider boards that have a much more direct responsibility? So I think it sounds to me like an area that's ripe for further conversation.
And there's a lot happening in that space, so it would be good to bring a today.
Okay, I'm going to take Michelle, then we're going to.
So Sam just triggered a thought for me really, and maybe for the quality committee, just think about how you not monitor, that's the wrong word, I don't mean that, how you look at and show yourselves about provider respecters and quality framework, because that's obviously part of the ICB's role / region role when we get that jigsaw puzzle sorted out. But I think that's quite a good tool to use to see, well, where are our gaps, to see, well, where are the ICB's gaps and are they the same, and is there anything that needs escalating through that process?
No, I think that's, if I could I think that's really, wise thoughts. And one thing that we've been very clear about in the last couple of quality committees is that we will have to reshape what our primary focus is as the landscape develops. If I use that.
And I think for all committees,
so we will. Thank you.
Yeah, I think for all committees, there's something about almost designing the future as well. Different. So just a couple of things probably kind of go to consider that. So I think the struggle I've always had with the BAF is that part of this is about ICB risks and part of this is about system risks, and around trying to capture both in one BAF is always going to be kind of quite complex. So actually, I don't think this is the only bit where we might want to look at the wording, because I kind of think there are two things at play running alongside each other which are different. Just as a tip off, Sean, when we get to the conversation around the performance stuff, so I'm going to come back to triangulation, because I kind of think that starts to bring together quality, performance and money into one place that actually enables us to kind of look at a broader level rather than having it in three different committees all in one place, to enable us to understand how those factors kind of work together, because they are linked, and I think that's really important. And then the other bit is not losing sight of the fact we're going to look at some insight reports later, whereby committees are talking to us about our immediate risks over 20. So the BAF isn't the only place where we actually locate risk. I think some of the more interesting stuff is happening within that insight report kind of space. So proposal there in terms of the wording, in terms of revising the score. What I'm picking up from the board so far is that people are quite comfortable with that. They think it's logical and pragmatic. Are people in agreement to those changes? Super. Thank you. And the second one is yours, Des.
Thank you, Chair. This it's B4 on the back. It's a new entry on the back, but it isn't a new risk as such. It's one that many committees have already been monitoring by the Corporate Risk Register. The reason we're including it now is due to new counter-fraud legislation around failure of boards to prevent fraud. And the requirement is that we do have a risk on the BAF that we are actively monitoring. So we are not flagging any specific or particular risk with this BAF. What we're flagging is that as a board, we have to acknowledge that there is an inherent risk. We have a suite of controls around what sits behind this, which we do manage through our counter-fraud specialists and also our internal audit. And that does come through our internal audit, our audit committee when we have those meetings. going forward, we wouldn't expect this to come via the Finance Committee. We would actually expect this to come via the Audit Committee, but due to timing of the new legislation coming in on the 1st of September, we didn't have time to do that. And we also did a session in the private board last month just to land this and socialise it and make sure people were aware of the new legislation and the fact that we were bringing the risk onto the BAF. And we will continue to obviously monitor the controls we do have in place through our counter fraud colleagues and our internal audit colleagues. And we've also agreed to do a board training session in the future on the implications of the legislation and also the ongoing requirement to monitor this formally as a board.
Superb. And I think it's really clear. Stuart.
I'm interested in why it's such a big risk that it appears on our BAF. Did you say it's a requirement?
Yes, it's an assurance. So we attended a webinar with Hemsons when the legislation was published, I suppose, for want of a better word. And they've said that one of the tests they will look at is whether or not the board is actively managing it through the assurance framework should anything ever come up. So it's around.
So it's a sort of best practice type recommendation that's come up.
Yes.
And the other is the scoring that we've adopted. So we put a lot of effort and resource, just been described, into managing, detecting, preventing fraud. Given the amount of resource we dedicate to it and the lack of alarming frauds that have been detected in the last little while, that score of 12 after mitigation seems pretty high to me. The chances of being sued for not paying attention look pretty low because of all the effort that we put in.
Yep.
So why is the score 12?
I think at this stage, because it's the first time round that we're looking at it, we just don't have a peg for it. And as I said, we will bring it through Audit Committee to have a more robust conversation around what we think is appropriate. At the moment, we've just gone in with where we acknowledging as we stand at the moment, we haven't tested it in that sort of way in terms of the BAF and how it relates to everything else. But
when I describe to our fraud prevention team the size of this risk, I'll take a box of tissues because they'll be distraught, I would have thought, at the size of this.
Indeed.
I look forward to future amendments from the Audit Committee in terms of that scoring.
It's because it's come through the Finance Committee and we've not had.
It has to start somewhere, doesn't it? Because I guess if it'd gone too low, people were going, "This is ridiculous. It's gone too low." So
it's just recognition of what's inherent in the organisation at this stage.
So I think we need audit to look at this at your next meeting, Stuart. I think that would be helpful. Andrew.
Yeah, I mean, I think it's probably too low given the risk of cybercrime, because that's the big one, and that's fraud. So I think overlooking it, I think putting a low is being naive. I think that actually the amount of times, I mean, our cybersecurity system, actually, when you look at how many times a day we are getting attacked, because we monitor it and where it's coming from, it's absolutely unbelievable. So and I last week, a couple of weeks ago, I apparently raised an order for 3 million quid or something. So actually, people are doing it all the time. It's just it's just good. And actually, to be really honest, we spend a hell of a lot of money on fraud and risk management, but actually our score's higher than that, and our score is a lot higher than that. And actually, you cannot score a green when you get assessed for fraud unless you've had fraud. That's the only time that you actually test your systems and processes. That one, you caught it, two, you dealt with it, and three, so you can go as far as you want. Fraud assessors will say that you're still at risk until you've actually tested your systems or they've been absolutely hammered by somebody. So
it sounds like we should invite Andrew to the next audit. Yes. Those are all valid points. I was just going to put, we sort of carve out cybersecurity under the data and digital.
Yeah. I think it's a link, isn't there?
There is definitely
every link. So
it's fraud things at the moment. Actually, it's more. It's finishing companies. You've got to understand. This is sending companies under.
Yeah,
you know what I mean, and I've had a non-exec whose company's gone under.
Yeah.
So actually,
you can't underestimate it.
So look at Jag Land Rover and such like that.
So Des, final word.
Yep. So there's obviously we need to also look across all the committees and we need to pick up all the individual areas as Stuart's just pointed out, we do have a separate risk around cybersecurity, but all of those need to be taken in together to arrive at where we are in terms of the overall risk. So it's a mark in the sand at the moment, and that's a conversation to continue having with our counterfraud specialists. Also, just to say that rating was on advice. We did work with local counterfraud to come up with that. So we didn't sort of entirely make it up, but so we have got a basis for it. We just need to keep having a conversation around where we're.
Okay, Stuart.
I've got a point on a slightly different point. There's medium-term financial objectives mentioned in the E section of this thing. And I think those should essentially refer to uncertainties in transformation until we have more certainty about what's going on with our transfer of responsibilities, the regional model and so forth. So I know there's a separate transition type risk, but I think so short-term finance is short-term finance, but the medium-term stuff clearly needs to align with our new responsibilities, which are as yet ill-defined.
Yeah, so probably two actions. So first of all, I think we just need to agree a starting place, which is by asking the board to agree this as the starting place for B4. And so are people happy with the starting place? Because the conversation, I think the next action is the conversation needs to be picked up at the next audit committee to look at that, to kick that around, to come back with any changes here. And then the second thing that you've just kind of thrown in there in terms of the need to potentially go back and look at particularly the finance ones in the context of where we are now is probably
there's an ICB pure risk and a system
risk as well. So if we ask for the next public meeting, Des, that we have a look at those and then bring them back.
Yes, those specific risks are around the medium-term strategy, which is something that we'll have to bring back in the next quarter anyway.
Yeah, so it makes sense to do those together.
So we can bring that together, and that should directly address our future direction of travel and the risks. And
which hopefully will be clear about that point.
Yes.
He says very, very optimistically. Okay, so thank you for those. So that's the longest discussion we've had around the board assurance framework in my memory. So that's actually quite good. Okay, so we're going to move on to governance items reserved for the board. Not the most exciting title, Jane, for your updates on this.
No. So you've got the paper in front of you. There are two main items for us to discuss. One is the scheme of reservation and delegation, which has been brought into line following our July meeting where we did the scheme of financial delegation. And then the second one is a number of terms of reference for the board subcommittees that you have in front of you. So I'll take them one by one. So the first one, the scheme of reservation and delegation, there are some key updates that have been amended from that. So it's now aligned with the scheme of financial delegation. It's aligned to the updated ICB governance and reporting structure. There's some general housekeeping amendments that we've made. Two main areas is the place director delegation. So a place director, a joint committee can commit within their delegated authority is included in that. And the second one is the individual funding requests, which will be approved in accordance with the scheme of financial delegation and the funding request terms of reference. So shall I take that one first?
So that they're just kind of updates and I suppose kind of tightening some stuff up after the review. Are people happy to accept those?
Yes.
Okay, done. Terms of reference. What was my favourite thing? Terms of reference.
I know you really do like terms of reference. There are three terms of reference that you've got for board approval today. So you've got the Remuneration Committee, Quality Committee, Finance Performance and Contracting Committee. You've got outlined for you what those changes are, committee by committee.
Yeah.
So I'm recommending those to the board for approval.
So these are basically the annual kind of review, and just to I suppose kind of pre-warn you, there will be another tranche coming in the next kind of public meeting. So if you find this exciting, there's more excitement to come. So these are largely as part of the review. I think some of these are tweaks, and I kind of think some of these are also about being quite pragmatic about where we are now in terms of our move towards a future ICB. So I think the last thing we need to be doing with committees is that we need to make sure there is transparency within committees, but actually we need to avoid an issue of quoracy within committees if we can. You know, making it difficult for ourselves to make decisions is never good, and we should only be doing chairs actions as an absolute emergency rather than as business as usual. So are people happy with those changes, those terms of reference? Superb. Thank you. So we move on to moving on to strategy now. So update from the acting chair. I wasn't really going to say anything apart from the report that I've kind of given you, which has given you, I suppose, a little bit of an oversight of some of the things that I've been doing over the past month. I think we're going to talk, I think, in part one and part two around the work that we're doing around organisational change and the move towards the new operating model. I just kind of wanted to say publicly that the amount of work that's gone into that is immense, and I kind of really, want to say thank you to everybody, including the staff who helped us, the design group, in terms of getting to where we are, in terms of what is a really difficult ask, and I cannot underestimate, that we are designing a new organisation in a climate of uncertainty, where actually the longer this kind of goes on, the impact on our staff, I am very conscious of that, and I'm very empathetic to where we find ourselves. But actually that has making sure we get that right and we design the right organisation moving forward, a high-performing strategic organisation, is going to be incredibly important. So that has kind of occupied me quite a bit along the transition committee. You will have sensed from the number of items of governance coming through the board that we spent a lot of time looking at our governance as an organisation, trying to kind of unpick things that we could do differently and making things much less complicated. I am very conscious, I think I said in this seat a couple of months ago, I'm very conscious of the volume of meetings that we all kind of put in the diary. I do wonder how we do work sometimes when we just have meetings after meetings. So it is about, leaner and meaner. It is about focusing on action. I'm a great fan of meetings, but actually there is something about how we free up the space to do the stuff that we kind of need to do. So the governance piece has been, and the governance team, I have to say, have been very receptive to the opportunity to reflect on how we work kind of at the moment. We are in the process. I think I spoke last time around the Integrated Care Partnership, which, as you know, the 10-year plan tells us that the Integrated Care Partnership will go as a statutory kind of partnership, moving forward. We had already committed, I think, as an ICB, that we wanted to continue our partnership arrangements. I don't see how the ICB can deliver what it needs to deliver in the future without the strength of its partnerships in terms of local government, acute, primary care, community, mental health, learning disability, autism, the voluntary sector, the independent sector. So our commitment to having a partnership and continuing to support a partnership remains, and I think the mood music is that those partnerships will still be important, they just won't be statutory. And I think we are exploring at the moment, Teresa, Jane and I and Anya, around the role of that partnership in terms of our combined authorities as well. So we are moving towards our first meeting where we're proposing a different way of working, something which is much more inclusive, so not a set membership, that we do things thematically, and we've got an opportunity for anybody who is interested to be part of discussions, because actually that's where the change will happen, and that's where the creativity and innovation. We're standing down the Futures Group, and a huge thank you, particularly to Charlie, Jeffrey, for leading the Futures Group in terms of the innovation, creativity, the legacy that we have from the Futures Group now, in terms of the born-in work, and I think the work around frailty and children and young people. We need to capture that innovation and creativity within an integrated care partnership kind of moving forward. The world has changed, but I think the appetite to do things differently and together has been really strong, I think, from those conversations. I continue to meet with all of you on a regular basis, and thank you for all of the support I think you've offered us through difficult times. And I kind of think this is a really challenging time for the ICB. I'm also conscious this is a challenging time for our partners, and this is a challenging time for local government. But actually, what I really sense is from talking to you all individually, collectively, is actually there's a commitment to make this work. And actually, we see the opportunity and the value of the work we've done already, but actually the opportunity as we kind of move towards a new operating model. So thank you for all of that. And I've touched on the work that we've been doing with the mayoral combined authorities. I think there is huge opportunity for the NHS as a partner with combined authorities. We, of course, have 3 within our patch. And we are currently in the process of trying to work through with the mayoral combined authorities what those duties the 10-year plan talks about are going to be in terms of our relationship with mayors. So it's actually been quite busy, but that's kind of where I've got to. Even busier than me is Teresa.
Okay, so I'm not going to go through all the areas in the report. There's just a couple that I do want to pick on. But I'm happy to take questions on any of the items in the report. I just want to talk sort of more globally about the whole sort of organisational change perspective. So in the report, I've put the information around the ICB clustering arrangements nationally. So board members have now got a picture of what the future ICB footprint for England looks like. The thing that I want to add is obviously we have the long awaited model region document was published on Monday evening. And obviously we will need time to review that and to digest it. And really we've done an initial sort of review of it, but particularly looking through the lens of, is there any significant impact on our proposals, our structure that we have developed for our new arrangements? And at first pass, there doesn't seem to be any initial things that we need to address in terms of our structure. There's got to be further work now to actually understand the impact on the new ICB going forward in terms of where we sit in the operating framework, our responsibilities versus regions' responsibilities versus our expectations of providers. And the final bit is in terms of clearly NHS England at regional level will have an oversight of ICBs as well as the wider system. So what are our responsibilities as a board as part of that oversight arrangement? So there will be we can bring something back to the board in terms of more detail in our assessment of that once we've gone through that process. I just want to add the discussion we've just had around quality in relation to the BAF is really a link to the Royal College of Nursing report that I've listed in the report, because one of the concerns, obviously quality oversight has a tendency to sit within nursing portfolios, and there has been obviously lots of media attention about are ICBs in the future going to have directors of nursing, etc. And that is perceived to be a significant risk in terms of some of the quality oversight, not only of contractual quality oversight, but actually making sure that we've got the right quality metrics into contracts in the first place. So I think it's a really timely report from the Royal College of Nursing, just to reinforce some of those messages in respect of that. So the only other thing I wanted to talk about, and I will come to Sean to talk about a little bit around the National Oversight Framework, is now that we have had the league tables, if you like, published. There are supporters of league tables and there are cynics in relation to league tables. And I think you can't argue that some of the metrics on the league tables are really important. The long waits in A&E, cancer waiting times, etc. Nobody can dispute the importance and value of those. I suppose my view and advice to the board is actually we need to see this as just one part of the jigsaw. It doesn't tell us everything about what's happening for patients. It doesn't tell us where those pockets of excellence are, particularly as we've got the financial override. Doesn't necessarily tell us if we've got, say, pockets of excellence in some services when they can only be at a level segment 3. And the final thing that I would just say is we need to learn the lessons of history. There is a value to league tables in terms of that, competition, really useful. But we need to learn the lessons of Francis. And if anybody needs a refresh on Francis, you only need to read the press statement that was made on the day that the reports were published. But that seeking of specific organisational goals in a cost-constrained environment without that broader triangulation, listening to patients, understanding of quality, etc., would be a significant risk. So my advice to the board is it's a part of the jigsaw. It doesn't tell us everything, and we need to make sure that we still focus on everything.
Okay, that's helpful.
So
Mark, sorry.
I was going to let Sean just.
Oh, sorry.
talk a little
We'll
bit
go
about
Sean, then come to you, Mark. Sean.
Thank you, Chair. And obviously, mindful of what Teresa just described around the context as to where it fits and the pros and cons of that. But we've been briefing the board on this coming for some time, and it has been delayed for a variety of reasons. But just to put some substance of that in terms of what that means for our patch in relation to the provider position. So each provider was ranked in terms of the position for acute, for mental health and community, and for ambulance positions. And they were put into segments 1, 2, 3, and 4, one being exceptional and 4 being the most challenged. And as Teresa's referred to, there was a financial override that meant that, irrespective of its segment, if they were in receipt of deficit support funding, then the segment above would naturally kick in. So just in terms of scores on the doors, just for factual reporting back from the publication, Humber was segment 2, Harrogate was segment 3, and the other key providers were segment 4. In terms of rankings, that put Humber 22nd out of 61 in mental health and community, Harrogate 35 out of 134 for acute, York and Scarborough 118th out of 134 for acute. The both could obviously provide to community and other services as well. Huff 124 out of 134 and NY 125 out of 134. From an ambulance perspective, NYs were deemed to be the most top of the league, if you like, for ambulance providers, but EMAS were second and YAS were third. So two ambulance providers in the top 3 for our patch for completeness. The intention is to refresh this every quarter, and that may see some movement up and down in that space. But as Teresa's report does refer to, that each provider now has been asked to do a provider capability assessment for submission in October, and that will be used, amongst other things, to determine whether those providers in segment 4 justify going into a provider improvement programme, and in segment 5 as a consequence. In terms of the segment 4 position, our 3 providers in Humber, North Yorkshire, a total of 8 in segment 4 in North Eastern Yorkshire.
Thank you. Then very much a point in time. Mark?
Yeah, it was just a point that I was mulling over, but it kind of builds on what Teresa and Sean have just said, actually, which is there's been a lot of publicity of these league tables. There was a full league table in a paper I saw yesterday, where if I was a patient, one of our trusts, I might take a particular view based on what that was. And I think particularly reflecting on the fact that the league table is not purely about patient care or outcomes. And as we've said, there's quite a significant financial aspect in there, which, to be fair, was reported in a quiet way, but a quiet.
Secondary, yeah.
I just wonder, do we need to do any kind of messaging or communication to our populations, or indeed at sites, to let them know what this really means? Because I think it paints a picture which may not be quite as clearly describing the patient experience and outcomes as you might think. So, open question.
And I think that's really interesting, because I saw some stuff, certainly on the local news, where patient experience was, actually, I've had great care, this has been really good, I don't recognise this. So I think that difference between the two, I think, is really interesting, because actually these are really hard measures, whereas actually patient experience from the people, and admittedly it was 2 or 3 people I spoke to, were telling a story based on personal experience, which was incredibly positive around systems. So, Anya, and then Michelle.
I was very much going to echo what you just said, Chair. So if I just take a step back, there has been some provider level communications that has been issued, particularly Humber Health Partnership were in the regional media, as the chair's just alluded to, and on websites, on the ICB website, to try and help the public and patients understand and navigate this information a little bit more. But as the chair's just said, I think what was really helpful yesterday is around the media piece was patients coming out and saying, and it builds on Teresa's point around the points of excellence of saying, actually, this doesn't feel like the care that I received. Notwithstanding, there were also comments that built on your original point to say, I'm a little bit concerned that the providers in our area are so low down. So I think it will just be a sort of evolution, if you like, an iterative conversation that happens, and it will be interesting to see how prevalent this is in the public and patient conscious, if you like, as we move forward. It's very early days to say, I think, but I think it was helpful that the patient voice was front and central yesterday.
Okay, so we've got, I'm going to take 3 comments and then kind of move on. So we've got Michelle, Simon, Michelle.
Yes, thanks.
We're not you, Michelle. That Michelle, not this Michelle.
I think you meant me, didn't you? That is a really good comment. It's one of the things that providers have been saying in relationship to interpreting the data. That's no disrespect to the public and what have you, because even some of us that work in the sector have been spending months trying to look at the data and look at the models that they've been using, and some of the data that's still not correct. For example, one of ours, from a waiting time point of view, we haven't got innovative speech and language therapy, but yeah, it says that's one of the 3.52 areas. So it is really subjective. So I think for us, what we do need to do, both as an ICB board here and also to empower our providers, is to continue to give those positive, reactive messages. I know it's difficult when, if you're 137, that or 136 or whatever, but I think it is about that, because we don't want to deter people going into hospital or going to seek help and advice, because they're a bit concerned because you're so far on this league table piece. And I think that's what we've got to counter, to say, look, still go to the hospital, still approach the hospital and what have you, because we will do a great job, and they're only set metrics. The other thing that I'm sure people are aware of, that the public can go into the Foundry and the data set and drill down into a lot of the data as well, which may or may not be helpful in relationship to that. So I do think there is that constant communication message to patients. I also think there's a message to staff as well, because staff are working really hard in exceptionally difficult circumstances in all provider organisations. And healthcare staff have always been traditionally quite competitive. So I think I would be quite even more demoralised to know where I was on a league table if I thought I was doing a really great job. So, and we have that throwback when the staff survey comes out as well, when we get into a table. And we're getting into a bit of a league table frenzy. And I think from an ICB point of view, we think that we need to feed into the centre, I know providers are, that it's not always helpful. I can understand some of the reasoning behind it. A little bit as a provider, and I speak on behalf of all providers. From an NHS point of view, and the local charger will say otherwise if not. But sometimes they're helpful and sometimes they're counter helpful. And I think we've just got to make sure there's that balance. I think if a statement can go out from the ICB after the meeting, say, I think that might be quite helpful to say that we acknowledge the segmentation, we're working with providers, there's a lot of good stuff still happening and a lot of good care out there, and staff are supported. I don't know, just a suggestion. So
I think we can take that as an action, I think, Michelle. So I think that's really cool. I think the impact on staff of the negativity of being where you're perceived to be in a league table is something people probably haven't thought of. So I'm just going to take these 3 kind of contributions and then kind of move us on. So we've got Simon, we've got Michelle C, as I'm now calling you, and then we've got Martin.
So I'd be wary about going down if we take the finance out, what's the performance stuff look like? Because actually it might not change the relative ordering of where our local trusts are particularly. So I'm not sure that, and I'm just not sure that it's worth us getting into playing the game. If journalists and I don't know, we've got a public gallery, there may be some journalists in, but if journalists in general weren't so lazy, then they'd be doing the league tables themselves anyway, because most of this is all publicly available data. And certainly I know in the past, local journalists, I mean, we know local journalism has been decimated over the last few years, but local journalists used to do league tables of GP practices, for example, based on the National GP Patient Survey, because it's publicly available information. The difference here is that the government are doing the journalists' work for them by publishing the league tables themselves. So there is just something that I don't think we should get too fretting about this, except in one regard. And I don't think it's necessarily about patient confidence and experience, because actually your own individual and your family and your neighbour's experience of what's gone on at your local healthcare provider is way more powerful than a league table published in a broadsheet newspaper that you probably don't read anyway. And therefore, I think that to me, I've never yet once had a patient who's asked me when I said, which hospital would you like to be referred to for this, who's asked me, well, where do they sit on a league table? They know what they think about their local hospitals, and it's got just as much to do with bus routes and how Granny was looked after on Ward 14 than it ever does about what's in a league table. Where I think it really matters is workforce. And we know that if you look at some of the areas that were in the lower segments of the league tables, they tended to be in the harder to recruit areas. So and they often were coastal, they were more deprived, of which, of course, that's the case for some of us, and areas that had less, for instance, things like training colleges, pharmacy schools, medical schools, that kind of stuff. So the work that Jane and you and others have been doing around our long-term workforce development remains absolutely key to this. And where I think they're not irrelevant is around staff retention and recruitment. Yeah. So the countering that we need to do to this messaging should be focused on workforce, both current and future.
I totally agree with that. And I think anything that we can use to positively thank and appreciate our workforce at this point in time, wherever you are working in health and social care, is important. I think I'm really committed to that. We are doing the most amazing stuff on a daily basis, and actually we need to hold on to that. That makes a massive difference. Say thank you and have gratitude for that. Michelle and then Martin. Michelle C, as you now know.
Thanks. I just wanted that conversation to play out before I came back to something that Teresa said about patient experience in relation to patient safety. And given the timing of this board, I didn't want to wait until the next one before we recognised the rollout of Martha's Rule.
Yes.
So Martha's Rule has, for those of you who don't know, is related to Martha Mills, who died when she was 13. She died in 2021. It was her birthday on the 4th of September. And the Acute Trust in particular have been rolling out a pilot to recognise Martha's Law, which in summary is 2 bits. It's that you recognise and listen to patients and document their concerns on a daily basis when you see that individual. And secondly, if the relatives are not getting the response they want and traction they want for a review of their loved one, then they have a right to a second opinion, if you like. And what the pilots have shown is that it does make a difference. The documentation is better, and it has led to changes in care through concerns of relatives. So I just wanted to mark that. And a couple of other bits. Flu campaign, a lot has landed with us and all providers to really push on frontline staff vaccination against flu, which has dropped to about 37% last year from where it was. Really important in keeping staff and patients safe.
Yeah.
And the National Maternity Review, we still do not know who the 10 chosen providers are, and we won't know until about mid-September.
So keeping watching brief on that. Yeah. I think that's really helpful. Martin.
I completely recognise everything that everybody said, and particularly Teresa. I think performance tables have limited opportunity to understand the whole system, but I also think we want to be a learning system, don't we? So is how we use the data that's underneath that to make sure that we don't just sit back and say, actually, we accept it. So how do we get to that data to understand what we want to learn and who's best in class in particular areas, and how do we bring that learning back into the system?
I think that, and I think that where I was going to go to in terms of kind of moving on is that I think there is something about the league table as a point. I think what happens as a result of the league table, and actually the plans that people put in place and how people respond to that is the most interesting bit, isn't it? It's the action that people take, rather than just saying this is where we sit on the league table. And I get that whole bit around competition and are we measuring the right things, and actually what's the impact of the league table. there is more than just a league table. And I know that the complexity of organisations is there is stuff that is not being measured, which is stuff that actually is we should really be proud of. And actually, we are making a tangible difference on a day-to-day basis across our whole kind of system. It's a snapshot. It doesn't stop us from what we're doing. But actually, I think what I've sensed from everybody around this table is that desire to continue to improve and reflect and to really kind of focus on patient experience as being the key driver. And actually, whatever our operating framework looks like in the future, patient experience is at the heart of what we do. If we can't say we are making a real difference to Betty at number 3, then we need to kind of think again. I don't know if there's a Betty at number 3, but I'm hoping there is. Okay, so that's been really helpful. And of course, you get a chance to do even more of your updates in part 2. So if you're kicking yourself for not having asked Teresa a very technical question about something in a report, you will have a second go. So, Jane, equally exciting, we're going to move on to ICB transition. So the update on where we're up to in terms of our transition and the headline feedback from the transition committee, which met last night.
Yes, it did. I mean, there's limited information to share. I think you're probably aware of this with the public information that is readily available. So there hasn't been any further movement on the funding for transition for ICBs, which means when we did meet yesterday as a committee, we're not able to progress our case for change, if you like, for our organisational change for the ICB. So that's as it was. And when we meet as a transition committee, we review that every time and review what has or hasn't changed to enable us to make those decisions. So we're not any different to an enormous amount of ICBs nationally, unless you're in the position of clustering or merging, where there are some differences for ICBs. So in headline terms, that is the case. We did have a staff briefing last week. It had been a number of weeks since we'd had a staff briefing. And if you remember, we stood them down because there was very little information to share with people, and it was creating levels of anxiety in terms of the feedback that we were getting from our people in terms of continuing the briefings. But because it had been 7 or 8 weeks since our last one, and because summer had more or less been and gone now, hasn't it? We thought it would be best to bring everybody back onto the same page and update people with where that was at, which we did last week. We ran a poll before we did that, and I think it was almost a 60-40 split in terms of 60% saying they would really welcome a briefing and 40% not. We haven't put any further briefings in. The briefing itself, when, as you would expect, there's very little that we can share with people. It's the same as I've just shared with the board, but it did allow us to take questions from the workforce and update yet again our frequently asked questions. I think we've got about 250 frequently asked questions now in there. And it allowed, because there'd been a number of different conversations happening, and I think it was the select committee yesterday, wasn't it? And I haven't looked at the notes from that, but the bit that I did see in the headlines today was just that we should get further information in the next 2 to 3 weeks from Jim Mackey, who is in detailed conversations, it seems like, with the Treasury. So perhaps some renewed vigour to try and resolve this stalemate that we appear to have. I don't think there's much more, unless Teresa, you want to add.
Sorry, I should have mentioned, alongside the model region being published, there were a suite of guidance documents that are associated with services that had previously been identified as those that may transfer. And I think we've reported that we do not expect those to transfer. So that includes guidance on EPRR, safeguarding, SEND, children's continuing care, CHC. So again, a bit like the model region, we'll be reviewing those in depth, taking the assessment through to the next transition committee to assess if there's any changes that we need to make in terms of our proposals.
Yeah.
I suppose just to kind of acknowledge that, you know, we, as we've talked around on this table before, we are concerned around the ongoing delay kind of in this process, and in particular the harm to our staff within the ICB who have been operating in a climate of uncertainty since the first announcement in March. Yes. And I just wanted to offer an assurance that our commitment to supporting our staff, through what is a really challenging period. Because of course, it is business as usual. We are trying to deliver a challenging plan, and people are doing a fantastic job with some certainty over them. But also, an assurance that we are doing everything we can to raise that concern at a regional and national level. And that, we have something written to NHS England to say, from our point of view, we are committed to doing this sensitively and well. That we need to do that together, and we need to do that, have an idea about the time frame for this as well. I'm very conscious we are now in September for something that was trailblazed in March. So I just wanted to give that assurance that we are very, very aware of the impact of this, and just to acknowledge the support I think that you've all offered us as partners in terms of what is a really difficult time. This is ultimately about people. And it's not about organisational structures. That's lines on a page. It's people that make organisations work. So we'll have a chance to pick up sort of more of this, I think, in part two, won't we?
Yeah.
Which is good. Okay, so we're now going to do so. Welcome to Lisa, Emma, Karina, and Tariq joining us in terms of an update in terms of Catterick. So whilst we get yourself sorted, it's lovely to see you, by the way. The last time I saw you, I was wearing a hard hat and high vis, which I wish I had kept, but that's just a personal thing. I've been around this board table for far too long, and other people have been around even longer than me. But I remember a meeting in the early days of the ICB, when we could afford to meet in hotels, where we had the initial conversation, didn't we, Lisa, which was around Catterick and around the opportunity. And as a board at that point, we just went, why would we do this? Actually, where we are now with this, I think for me, is a really good example of what can you achieve as a partnership by thinking and working differently, by having sheer grit and determination about wanting to kind of make something happen. And I'm looking at you, Lisa Pope, but also actually a really, really good example of actually what's the opportunity we have in the future. So Teresa and I went and did a visit to Catterick. It feels like a lifetime ago, but not long ago. And I have to say, I was absolutely overwhelmed in terms of what that looks like, what that feels like, but also the enthusiasm in a room for what's the potential. Because actually this was more about services in the building. The building is the catalyst for, I think, really quite an exciting conversation. So what I wanted to do was to share that with the board. What I want to be able to do for the board is to kind of say, despite everything we've talked about in terms of league tables and in terms of transition and delays and things, there are lights at the end of the tunnel, and there are things that this board kind of needs to celebrate. So helpful if the four of you could do introductions. I know you, but the board doesn't. Some kind of introductions, and then we've got half an hour to kind of allow you to kind of give a presentation that does justice to the work that you've done, but also for the board to be, as I said at the start, curious and challenging.
Yes, and before they do that, just say a few words.
Do you know what I was going to say? Yeah. Say to my list, Sean Jones to Sean Jones to.
Sweet, to be fair, and quite apart from the distinctive and unique nature of you wearing a hard hat, this is a very distinctive and unique piece of work for the reasons that you just described. And colleagues here and others behind the scenes have put a huge amount of work over a significant period of time. So with that brief introduction, I'll ask people to introduce themselves and recognition that this is a very, very positive piece of work, and something that we should be really proud of.
Over to you. Do you want to lead, Lisa?
Perfect. Thank you. Thank you, Jason. Thank you, Sean. And thank you to the board for inviting us to talk to you this morning. I'm Lisa Pope. I'm the Deputy Place Director for North Yorkshire. Go to Emma.
Hi, thank you for having us. I'm Emma O'Neill. I'm the clinical lead for CICC for the ICB.
Tariq.
Good morning, everyone. My name is Colonel Tariq Ahmad. I am a military GP, but I also work in the NHS as a GP, being out of hours. And I've had the privilege of being a patient in the North Yorkshire ICB as well, so I have some experience. And I'd just like to say thank you, firstly, to the ICB before we start for engaging with Defence on this. And Jason tells me it was about 3 years ago that a similar meeting to this signed off. And it's a real privilege to come and see the sort of top tier of the ICB in work and have the opportunity to share some of the work that I've been involved with probably for since about 2019, actually. It's really encouraging to see that it's coming to fruition soon. So thanks for the opportunity to coming and talk.
Hello, my name's Karina Deer. I work for NHS Property Services and in the estate strategy team. We've been providing stateside commercial advice and support on the scheme. We've been involved since 2015.
Yeah.
So it's been a long journey and really exciting to see the development. Particularly, I would say the infrastructure will happen, but the clinical development that's going on is really exciting to see.
Superb.
Okay, I'm going to see my slides are kind of flicking through behind us as somebody driving.
See him there.
Okay.
Yeah, they're over here as well, Lisa, if you want to.
Thank you.
You may want to read them, but
No,
that's what we're seeing.
So we'll just kick you off with an idea of our vision, which is, as you can see, this is what our building is really now starting to look like. Anybody that goes past it will see it's covered in horrid purple at the moment, but it won't stay that way. The thing is gargantuan and sometimes feels like a fairly significant responsibility to have been driving that since the start, but it is incredibly impressive and it will deliver state-of-the-art health and well-being for the whole of the population. So the idea was born from a need for the NHS staff, patients and for the MOD staff and patients, but the offer is for the whole of Richmondshire and is about our rural as well as our military populations. You click on to the next one. As Karina alluded to, her and I have been now working on the scheme for 10 years in November. And apologies to people who might have heard this story before, but this is usually where I kick people off with the programme because it was born out of a first meeting that I went to when I was new enrolled in what was then Hamilton, Richmondshire and Whitby CCG, going out to meet people on the patch. And I went to a mum and baby group in Catterick. And at that time, my children were, about 3 and 7, I think. So it was very much my comfortable place at that point. And it so happened that Kate Davies, who is the National Director for Armed Forces, Sexual Health, and a few other things at the NHS board level nationally, was also on the garrison site. And we had a lovely time and lots of cups of tea, talking to lots of lovely mums and cuddling babies. And at the end of it, somebody who had said nothing throughout the whole meeting told us her story of how her husband, who had been serving personnel, had died by suicide, having felt that he couldn't access services for his mental health. In those days, if you declared a mental health problem, you were demoted, you had a loss of income, and you therefore suffered as a family because of that illness. I hasten to add to MOD colleagues, things have changed a lot in 10 years, but this was the story of this person initially. And both Kate and I were really struck by the fact that this woman was therefore on her own. She had 3 children under 5, and her husband had died in horrible circumstances. As a family, they'd each presented to different practitioners, both on the NHS and on the MOD side, and nobody had been able to put the story together and think, what can we do to help this family despite everyone's best efforts? Kate and I came away from that and thought, we can't just leave that, can we? That's too big and too important a thing for us to not do something about. So I wrote an elevator pitch for Kate to say, could we possibly go somewhere with this? And do you think you might have some money, please? Because as per usual, we've got none. So fast forward 2 years and a lot of work on the part of Karina and I and lots of other people. And we put together a feasibility study to say we probably think we could do something with this. At that point also, the NHS estate was really struggling. For those who might have seen it, Harewood Practice does an amazing job with a very complicated caseload, but they're in a horrible 70s flat roof building in Biggs. Likewise, MOD colleagues in DMS, which is Defence Medical Services Practice, are in a repurposed accommodation block, I think they're still there, and didn't have a decent building from which to operate. So we were given the go-ahead. We then wrote an outline business case that was approved in 2020, full business case in 2023, and now the behemoth is rising and we hope to open in spring of next year with a following wind. I think we're there, don't we? So I'll pass on to Emma because really I've given you a sort of snapshot, but this is really born out of the data and also the health inequalities work that we then looked at. Obviously, spidey sense and a very moving story wasn't enough to get us to where we've got to. So we really had to drill into the data. So Emma, I'll pass to you.
Thank you. So I just want to spend a little bit of time really focusing on health inequalities, because Catterick's quite a significant example where when you look at the higher level data, it masks what's happening at that lower level in those rural kind of localities and the experience of communities within there. As Lisa mentioned, Richmondshire faces significant challenges because of rurality. There was a 2023 Health Watch survey that showed that 2/3 of respondents in Richmondshire faced difficulties with access to health services because of rurality. And in fact, the third that said they didn't said that if they didn't have a car, then they would face those challenges as well. And in every engagement event and kind of cohort workshops that we've been running, transport comes up time and time again as an issue that people are facing. In fact, we had one health professional say that some of their patients are declining chemotherapy because of the access to services and the time it takes to go to secondary care, which is really not a great situation. Richmondshire also has the second highest proportion of veterans in England. 9.5% of adults over the age of 16 have previously served, and that's, as I say, the second highest proportion in England. And we know from both national and local data that veterans are significantly more likely to be disabled than the general population, with some surveys reporting up to 47%. They're also more likely to experience loneliness, with around 1/3 reporting feeling lonely compared to just 7% of the general population. And that is reflected in the GP patient survey data that we have for Catterick Village and Harewood, who are the two local GP practices to where CICC is being built, who have the highest reported rates of social isolation within Richmondshire PCN at 15% and 10% respectively. At Harewood Medical Practice, which serves many military families, we're seeing significantly higher rates of smoking and obesity than both Richmondshire PCN and the England average. For example, with Harewood smoking prevalence, this is 15.7% compared to 14.9% for the England average, and just 8.9% for Richmondshire PCN. And with obesity levels are 18% for Harewood versus 12.8% for the England average. So there are significant challenges there. What we've also revealed is that Harewood has a significant difference in life expectancy compared to the rest of Richmondshire PCN, where females are in the 20% lowest life expectancy in England, whereas the rest of Richmondshire is much higher. So nationally, we're also seeing clear barriers for military families in accessing care, from registering with GPs, from transferring records from one GP to another, and navigating repeated assessments for children with special needs as examples of that. And that's highlighted again in the military families engagement that we've done through the programme, where people are reporting loneliness, where they're reporting these difficulties in transferring care when they're moving around, and that adds to the emotional and financial stress. So one of the key takeaways is that this headline deprivation data doesn't reflect realities that the local communities are experiencing. Richmondshire as a whole doesn't have any LSOAs in the most deprived 20% of England, but that is misleading because military housing is providing, so the housing indicators are skewed. The military are obviously employed, and so that skews the employment data, and there may be spousal unemployment, etc. And the frequent moves that families make it difficult to capture data accurately. So even within Richmondshire, child poverty is at 23%. And then if we zoom into Catterick, there are some wards where it reaches 27%. So wards like Scotton, Hipswell and Colburn. So that's almost 1/3 of children experiencing child poverty. And we also need to recognise underserved communities, such as the Nepalese and Gurkha population within Catterick. These make up 2.5% of the local population, and that's 10 times higher than the England national average. And one of the output areas in Catterick has over 40% that are registering as other Asian. A 2017 health needs assessment for Gurkha and Nepalese communities also flagged that language barriers and low awareness of services was an issue for them. And that's reflected when Tarek and I went to the Nepalese community for an engagement there. They were also saying that language is a huge barrier for them as well. So some of the steps that we're taking as a programme include trying to develop a Brazilian model health integration project where a health and wellbeing coach will go out and actively engage with military families that have just moved into the area. So we're currently putting in funding bids for that. And we're hoping that we'll be able to expand that to veterans and possibly further. And just importantly, that helps us navigate the difficulties with different contracts. So currently anyone registered with the military practice is unable to access the additional roles reimbursement scheme goals that we have. So we're trying to just overcome that barrier there. We're also within our mental health work stream developing a transition panel where mental health care can be handed over smoothly from MOD to NHS within 6 months of a patient transferring from the MOD into civilian life. And within CICC, within the building itself, we're going to be developing a health and wellbeing model where we can have rotations of different themes such as CVD prevention, mental health awareness within the central atrium of the building as well. So this is just a snapshot of some of the inequalities that Catric's facing and some of the opportunities that we've come up with. So the main thing for us to take away is that data can just hide some of the realities that people are facing.
Rena? Thanks. So in terms of community ownership and engagement, we've been on a...
We'll just go to the next slide, please.
We've been on a journey of engagement, which started with the lovely picture on a page with the different pillars of community involvement and engagement. And as you can hear from what Emma was just saying, that's continuing in terms of broadening that engagement and trying to target particular communities. There has been a process of joint design and development of the building, which has involved clinicians from across all the NHS and MOD, I was going to say organisations and teams, and has led to a significantly integrated facility where all the staff in public areas are shared and will hopefully facilitate joint working. There's been lots of work with military families in the wider community, making sure that the services and facilities meet the needs and experiences that we've heard about along the way. The facility's also been designed to try and integrate it into the local landscape, geography, and so it is connected to public walkways, cycleways that will run through the really lovely landscape grounds, which will also include space for community gardens, gardens within the building to try and bring the outside in and provide light to the clinical spaces, fitness trails to encourage wellbeing and social connection. And as Emma was speaking about there, what's been described as an active atrium space, which will have spaces for sit-down private chats or community groups to come and have displays and presentations, and a cafe space to encourage the public to treat it as part of the community rather than as something separate. And obviously and unusually for an MOD building, not behind the wire, so it will be a fully public space.
Right. Okay, next slide, please. So a little bit about the kind of collaboration and the integration piece. The Strategic Defence Review was published this year, 2025, and for the first time, Defence Medical Services actually got 2 pages on the SDR, which was unheard of, which tells you that they're taking it very seriously. But what was encouraging about some of our work that we were doing pre the SDR being reported was that Defence recognises NHS as a real key strategic partner for the first time and is viewing the NHS as a key potential asset in the event of peer-on-peer conflict. And that was kind of the thumbs up to us that we were already along the right lines in terms of collaborating with our NHS colleagues, working together to ensure that we were optimising treatment for our people. And when I say people, I don't just mean service personnel. Catterick Garrison is a really unique, interesting, thriving, multicultural community. The people who are there, civilians, a lot of them, a huge amount of them, support the garrison activity. They're either employed by the garrison or they're interacting with service people in providing services for them on the garrison. It's really key that those people are healthy and well in order to support us to do our activity. If you were to withdraw those civilians or there was a high sickness absence rate, things would really fall down in terms of defence. Equally, if it wasn't for the soldiers being there, the businesses that support them wouldn't be there as well. So they have this real symbiotic relationship that is key. And I think that this innovation of integrating more closely in healthcare is just simply an extension of that. So that's what I wanted to say in terms of the integration. Going down into sort of more specific terms, Lisa touched on it a little bit before. Having two primary care teams co-located, where my team might well be seeing the service personnel, but actually I don't know about that person's child who has special needs, learning difficulty, is waiting for a neurodiverse assessment. Actually, maybe the wife has complained that there's some domestic violence to her GP, but I would know nothing about it because the two GPs, guess what? They didn't have a chance to communicate, or we wouldn't necessarily know the way in. Whereas actually, we'll be sitting down for lunch having our sandwiches together in the same staff room when we're in the CICC. And some of those things might just come to the fore. Some of those challenges that face our families might be tackled in a much more collaborative way. I should have said earlier, Emma and I are the co-leads on the clinical operating model. And one of the things that we've been doing is running lots of workshops with different clinical areas from MSK, cardiovascular, respiratory, young people, sexual health. And some of the things that have been identified with those experts is they really want better access to MDT, to be able to get the right information early on to make an earlier intervention that's coordinated rather than this current approach, which seems to be that you go to this person for that opinion and then the patient comes back to you and then you go, oh, that didn't work. Getting the experts in the room early on, and not just within healthcare, but bringing in people from the education sector, community and local authority is key to sort of optimising and making the patient pathway much more efficient. And the building gives us that opportunity. So one of the things we're looking at is actually how do we do MDT with all the different services, and can we have a MDT coordinator to work cross organisations to pull in the right people at the right time. Next slide.
Okay, so CICC, as Tarek was saying, is bringing all these different partners together. So we have NHS providers, Defence Medical Services, local authorities, voluntary sector into a single integrated model. And so beyond co-location, the partnership is about shared clinical delivery in terms of joint governance with the programme board that we have. We've developed a clinical centre where we've brought system partners together across the various aspects to look at clinical quality, safety, patient outcomes across NHS and MOD services. We're looking at service innovation in terms of co-designing new models, for example, with primary care integration, digital first care, and looking at NHS dental access, possibly within MOD's facility. We're also looking at community integration, working with North Yorkshire Council and our VCSE partners very closely for things such as social prescribing, prevention and that wider wellbeing support, and looking at those wider determinants of health as well. So this will be the UK's first fully integrated NHS MOD facility. And so it's designed not only to share estate, but also to transform how we're delivering care.
Lovely, thanks, Emma. I'll try and speed this up because I'm conscious of time, and also the four of us could talk for the whole day about the CICC.
Please don't. Much as I love it.
So the next few slides are on neighbourhood health, really, and are just a bit of a humble brag on the fact that we were ahead of the zeitgeist. So in all seriousness, this is not news to anybody. We've been working around bringing care as close to home as possible under CCG and ICB days, and now neighbourhood health is what the 10-year plan calls it. Really what we've created here is a blueprint which is scalable for both NHS and MOD colleagues, and will be scalable for wider provider colleagues, to be able to synthesise different communities. So the fact that it's military and civilian in Catterick is where we're working, but we can use the blueprint to roll out elsewhere. We're also obviously ahead of the curve on the 3 shifts, so prevention is at the heart of what we're doing. Build is technologically enabled so that we can shift from analog to digital, and we're bringing as much out of hospital into the community as we possibly can. And that's all underpinned by a trusting partnership of colleagues from NHS and MOD, but also from our local authority, from the VCSE, and from all of our provider colleagues. So I'll skip through the next few really, because these are about our vision for neighbourhood health in North Yorkshire. But I think really the CICC is a microcosm of that. We Lou's here and been involved in the bid on that as well. And we have different models across North Yorkshire because no one size fits all, and we are a very diverse community. But the principles of neighbourhood health are the same. So they are a relational approach to system leadership, change that's grounded in trust and safety and shared purpose, and that shared purpose and collective ownership is absolutely key. And it's about rooting that system in commitment to prevention, to bringing care into the community, and then trusting each other to be able to care for our communities in the right way. So I'll skip through each of the next ones, I think, and hopefully the slides are available to the board, and we'll move to
circulate them, Lisa. Yeah.
Thank you. We'll move to the clinical operating model, which I think next up is that you, Tarek?
Yeah.
Yeah.
So I've touched on some of the MDT and how we've gone about developing the clinical operating model. To take Lisa's point of bringing care closer to home, one example that came out of the cancer workshop cohort was actually, we heard stories from clinicians that said we had examples of people in the rural Dales area turning down chemotherapy appointments because it was just too far and difficult to travel to James Cook University Hospital. And that was really tragic because, you know, and they made the case that with the long travel, even if somebody was driving, the nausea after the surgery was just unbearable. So after 1 or 2 treatments of an eight session course, they might say, you know what, I've had enough. So we looked at that, and actually there is scope to be able to deliver some of those chemo sessions from South Tees doing an outreach clinic using the CICC, which is absolutely fantastic for that cohort of people. They've been really forward-leaning in terms of that. And actually, because we've got X-rays and lead-lined rooms, they're also looking to do sort of low-dose radiotherapy treatments for sort of skin cancers there as well, which is just fantastic in terms of an example. So the clinical operating model, the common theme in the cohorts that we've done has been trying to look a little bit more closely at prevention of some of the things and early detection. And so we've really kind of took that on board and started to develop a health and wellbeing hub where you have a coordinated team who is able to use the atrium and use that as a more effective way of delivering public health messaging, supporting people to identify their illnesses, or if they've got unhealthy behaviours, get the support to modify and change those things. Further down the line, we want to really empower our patients to optimise their treatment. So we're looking, actually, we've got 2 sort of library classroom spaces, conference rooms in the CICC. So we're going to look to those to host peer patient groups. So you're a newly diagnosed diabetic, and you can meet with other newly diagnosed diabetic with the supervision of a clinician, and you can talk about what it means to you, how you're managing, and essentially get somebody to pair up and mentor as patients rather than constantly having that sort of power dynamic of the senior clinician telling them they're not doing well enough in terms of managing. So those are just a few things that we've touched upon. Is there anything else that I want to? There's one-stop shop. Oh, I think
so. There's absolutely tons that we've been coming up with and trying to progress. So some of the things are one-stop shop for diabetes, and we're, as Tarek had said earlier, we're really looking to mobilise the neighbourhood MDT that we're trying to develop. So yeah, but if we move on to the we're on the right slide now. That's fine. So just briefly, I'll go through what services are going to be coming into the building. So we have an NHS GP practice, which is Harewood Medical Practice, and then a Defence Primary Healthcare Group practice, which, as we said, will be integrated together on the first floor. So we'll have rooms alternating with those. We have a number of other partners coming in, such as South Tees, who will be providing services such as X-ray facilities, physiotherapy, midwifery is going to be based within the building. We've also got Tees Escombe Weir Valley, who will be providing the community mental health services, and HDFT, who will be providing sessional activities such as podiatry, GP out of hours, speech and language therapy, etc. And then we also have the equivalent on the DMS side, the Defence Medical Services side, such as the mental health team from Defence, and some rehabilitation services as well, and military dentistry. We also have services including Horizons drug and alcohol team coming in to provide sessions, and Your Sexual Health providing genitourinary medicine as well. We have a number of cross-cutting themes that's going across the clinical operating model, including single point of care, social prescribing, care navigation, and that interdisciplinary working, which will be running across that. On the right-hand side of that model, you can see the community services, which, whilst don't have space within the building or based within the building, they are able to access it through booking bookable rooms in the building if they want to, and we're also working closely with them with all of the work that we're doing across the clinical operating model. So it's a really huge opportunity for us to work more integrated and provide that holistic care for the patient. If we move on to the next slide, please, let's touch on this briefly. So we've developed integration roadmaps for each of the different areas that we have underneath the clinical operating model. This is an example of the primary care integration roadmap, and we're looking at what we can do even before we're moving into the building, and that includes things like setting up that MDT, and we have set up the clinical senate as well, so moving across there, and then looking at what we can do with CPD sessions, how we can work jointly together and integrate that across the system. And then moving all the way along to year 5, we would be looking at how can we develop those joint practice outputs in shared areas of care for primary care, and have a governance which is well established within CICC.
Thank you, Emma. So we'll move on quickly onto the build. We are nearly there now, so we won't take too much.
Just conscious of time, because I think people want to reflect back to you. So
we'll be
bear that in mind.
Thank you.
2 minutes. So we're on track with construction. MOD are delivering the development, and they'll be providing all the facility services. The construction's on track for a handover. We're saying broadly spring, but we're hoping by the end of April next year. And then move-ins and be operational by summer, autumn time. So that's all being planned at the moment. The construction's going very well. The building includes mechanisms to try and drive high levels of utilisation. And we are using open space to have lots of sessional bookable use of rooms, which has been supported by the ICB and will mean that we can drive the use of space. I think that's probably, we have lots of pretty photos we could share if you would like.
Thank you.
We'll just come and visit.
Yeah. Included some of me and Therese, which won't be shared. Being clear about that.
So we'll skip through the next few slides. We've done an awful lot of work over 10 years. There's still a lot to do, as you would expect, getting to the crunchy end of the build and starting to really realise what the integration opportunity is. And we've managed to summit quite a lot of mountains whilst we've been developing this. One we haven't yet managed to climb is dental. So we have use Helena Ebbs's phrase, a dental desert in Catterick. We have no NHS practices at the moment, but there is an opportunity. So there will be 20 new dental chairs for the MOD within the CICC. 20 chairs is a huge amount, and sometimes the MOD will need all of their capacity because they will need to mobilise or will need to treat a new group of incoming recruits. But there will be capacity for that to be utilised when it's not being used by MOD patients. We're right at the beginning of that negotiation with our MOD colleagues, but what we would like to do is at least start with an SLA that allows the MOD to let us use that capacity to treat military families, so families of people that are serving. We set out here the benefits of doing that. We've got a business case, which is currently in iteration, but that's really the next major step for us, is to try and use that capacity so that we can fix a really wicked problem, which is significant lack of access to dental at the moment. So we will come to the close, and Tarek, I will let you have the final word and then we'll open to questions.
Well, in the interest of time, it'll be really short. It's innovative, it's ambitious, it's challenging, and it's a big change. But hopefully in the longer term, you'll see some real health and economic benefits to both of our services and the population. Questions?
Thank you to the four of you for that. Trying to sum up the amount of stuff that you've done in that short pace of time, and sorry for hurrying you. I wanted the board to hear the story. I mean, Therese, before I go to other questions, you and I went together.
We did.
And we didn't stop talking on the way home, did we?
No, I think, I mean, the pictures at the moment don't do it justice. I know that's the finished sort of look, and obviously we had a different perspective on the purple.
I liked the purple.
I think, you know, how it's going to look is ideal, but actually it cannot convey the scale. I think that's the thing that struck me most of all, is actually the building and the site, and the real potential just as a consequence of that as we walked around. I think you know, the breadth of areas that you've covered, developed, the prep work, you know, has been absolutely phenomenal, and you can see it playing out as we were walking around and people were saying, and this is where we're going to do this, and this is where we're going to do that. It is well thought through in terms of, and people understand it already, so they know that there's not that sort of, we've got our new building, how we're going to use it sort of conversation. It's already well thought through, and yeah, interesting. I would encourage anybody that gets the opportunity to go and have a look at it.
So I'm going to take Simon, Louise, and then Michelle C, as she's now known. Simon.
So I grew up in this part of the world fairly nearby, and years ago, when I was 20 odd years ago, I was GP in London and wanted to relocate back to Yorkshire, and there was a GP job going in a practice in Richmond. And I seriously looked at it and talked about it. And the thing that put me off was that they had their practice area had a great big sort of indent in it, and the indent was Catterick Garrison. And they said, "Oh no, we don't look after that area because they're not our type of patients." And I was horrified, and didn't join that practice, and ended up going to Leeds. I don't know why, but anyway, and then eventually to Whitby. But this is nothing short of brilliant in terms of not only the and I know how difficult and how much work has gone in, but the level of model integration that you are planning is absolutely at the cutting edge of what neighbourhood health is all about. And you are absolutely to be congratulated on that. Both the managerial and clinical leadership that has been provided, this is brilliant. I'm just going to sound one slight note of caution or of concern, I guess. Given that I'm usually glasses half full, and it's just based on my experience in Whitby, where when the Whitby Hospital refurbishment took place, many of the things that you're talking about now were also talked about and trumpeted as the benefits of Whitby. And it hasn't been as easy. That the next 10 years is just as hard, if not harder, than the 10 years that's got you to this point. And some of that is to do with this really practical operational issues. The involvement of NHS property services, which I have to say so far sounds great, Karina, and it's great that you're here. It can be a bloody nightmare operationally. And the issues around things such as the costs and the pass-through costs of room rent, some of the issues around clinical integration and utilisation of the space that we have wanted to do have been hampered by the complexity of some of those relationships and the cost, even to the point of things like getting enough plugs in a room so that you can turn it into an office. It's that level of stuff that then stops the very clinical integration that the model that you're describing is trying to achieve. So I guess it would simply be to appeal to look at where we've tried to do this before and have hit obstacles. Please let's not do that again with what is an absolutely dream of a place that you're building there.
I'm going to say Louise, Michelle C, and then Michelle.
So can I come back on that?
Can we look at that bit then, because that relates to that, and then we'll go with the others. Go on, Michelle M, I'll let you sneak on in there.
First of all, thank you, great presentation, and as a clinician, absolutely fantastic. And so with that preventative hat on, I think it's absolutely great that we can do that, because it's so important to do that. And I think we really need to take lessons from that. To pick up the Whitby issue, that's exactly what I was going to say, because as a lead for Whitby, we really do. I'm sure you will have, but if we can share any of our experiences with that, because it does come down to the same people on that list of what we've discussed at Whitby and what we've been utilising at Whitby, and it just comes down to service mobilisation, the cultural piece as well. Some of the NHS establishments, no disrespect to Alan providing that, but also cost. So I just think we just need to, if there's anything we can share in relationship to learning, more than happy to share that from a Whitby perspective.
Yeah.
It's a really good point. I was going to raise that, but fantastic to see, because I think I remembered signing the paper off on that.
You were there on my day. But from memory, there were a lot of sockets.
Yeah, there are a lot of sockets.
I think I tripped over most of them, but there are a lot of sockets. Louise, and then we'll go Michelle C.
So putting my local director of public health hat on for North Yorkshire, this of course is brilliant, and military community, really important part of our community in North Yorkshire. I think it's right, basically lots of different communities, but of course Catrick and our relationship with our colleagues in the military is really key. Delighted that it's underpinned by looking at data and understanding health inequalities and being able to tell that story for North Yorkshire. And I know the public health team are all over this with you, Lisa, and the operational management of this going forward. And great to see our public health commission services right alongside. It's a great example of commissioning and provision all coming together to really serve the population based on understanding needs. So well done. But we will continue to be there with you every step of the way.
Superb. And I'm just going to note that there's a swathe of activity from this side of the room as well. So you're not getting off. So you're not getting a break, by the way, but I'm just telling you now. Michelle C.
Thanks for the presentation, and I've been dipping in and out over years with this work, and it's fantastic. And I have personal experience of that, being from an army background. We've been in the army their whole life, and we travelled around, and Castrick being one of those places. And I'm an old lady now, so that was a long time ago. But it sounds like the stories that compelled this means not much had changed from my family's experience. So that's great to see. A couple of questions from me. Can you see each other's clinical notes? Because we know information sharing hampers really good, safe care. That's one question. And the second is, this absolutely is a model of neighbourhood health. But if we want to expand and have an ambition to commission neighbourhood health, it can't look like this everywhere. It just can't. And we know it's not necessarily dependent on a building neighbourhood working. It's taken an extraordinary amount of time to get to this point for all the reasons we understand. So I suppose it's something about managing expectations and being really clear that innovation in the neighbourhood space doesn't have to look like this.
Yeah.
And it's unaffordable, isn't it, for one thing, but there are very different ways of providing neighbourhood health than this.
That's a really good point. So shared clinical notes.
So we can't see the notes at the moment because the MOD system is pretty much sort of locked down and only able to be used on the MOD net. But we're procuring very soon a kind of off-the-shelf commercial product there's two big providers that everyone knows. So it'll be one of those, and then that will allow us to have the shared clinical record and be able to see each other's notes.
And the timescale is that will be done before it. So
Right.
we'll be ready.
Right. Okay. Okay, so I'm going to go Andrew, Sean, Des, and then Jane.
James.
Oh, James. Sorry, James. I've confused your name with Jane on my. So
End up as well.
yeah. So we'll go James and Jane. Transition director.
You were dropping me off.
No, you're still on there. You just slipped down one. Andrew.
Well, I think Michelle's point's right as well, but having been involved with the ICC in the elderly frail one in Jean Bishop, yeah, people do get an expectation that the building sometimes becomes the sort of like the centre of the universe, and that's where you get the integration. I think that the integration and the success will be how much the community actually do utilise it. It doesn't get vandalised. If it's respected, and I know that in fact because that's what we tried to do with Lift when I cut my teeth on Lift, and my question was, and it's a bit on that thing about I mean I came to Hull, cut my teeth trying to deliver Lift, which is supposed to be about integration, and we built some really fantastic places. And everybody in them, from the baker to the butcher to whatever, they've all gone because everybody ran out of money. So they're all empty. And it's a shame. But the point being is that one of the things we couldn't do was get the GPs to even just change the colour of their chairs in reception. So GP1 had to be blue, GP2 had to be red. They had to have separate bloody receptions. They wouldn't work together. And actually it was an absolute nightmare. And it created, I think it was the thing we should have solved. If I look back in reflecting as being an old man now, is that actually we should have solved that problem there and then, because actually that became a blocker to further integration, really, I think. And actually has set a precedent in some of those places still to this day, where it's very much, this is my reception, these are my staff. And I think when we're in times where nobody's got any money and all that sort of stuff, we cannot work like that anymore. So I'm just making a plea that you may not have got them together because they're quite, but if you can work on getting them to sort of like even share chairs and reception, that's like a step forward. And I hope you have, because it was a big problem.
Are you going to tell us the colour of your chairs?
I was going. Well, I could tell you the colour of the chairs. I was around Lift days too, which just ages us, I think. One thing I'd say that's really interesting for me from a property perspective, watching what's happening here, is that oftentimes you have a whole program around delivering the construction, and that's driven contractually, and that's got its own life. What I don't usually see on these projects is the whole scope of programmatic clinical integration work that's happening here, and it fundamentally changes the conversation. And it would have even been great if it started a little bit earlier, give a bit more time, but it's amazing to see that, and from a non-clinician's point of view, and I think that should change the dial. I don't think it would address some of the issues that you're talking about infrastructure, because they all come down to money. And who's prepared to pay. So there's a big challenge in terms of contractual arrangements that support that clinically as well as property wise.
That's really good.
I'm sorry, I'll just finish up. And I think it's absolutely fantastic because it's a really it's a sad indictment on this country that our military service personnel are the lowest sort of like quartiles in health inequalities, things like that. And I think that the job that they do is a much better healthcare than what we give them. So I can only sort of think, well, this has got to be a massive benefit for those men and women and their families. So well done, yeah, great stuff.
Sean.
Yeah, I wanted to pick up Andrew's theme of chairs, and you mentioned about dental chairs. So I think speaking to Lisa last night, I think we need to follow up the issue that they raised about dental. See if we can look at that creatively and try and overcome the chairs issue that Andrew's just described in terms of optimising that. And we can do something creative. Obviously, the complexity of dental services does not have any limit, but nevertheless, we can try and work that through. So just to pick up on that particular action and bring that back, Jason.
I think it'd be really useful, because I kind of think there's something around dentistry is the one thing that everyone's talked to me about, and actually there has to be a way where we start to have a different conversation around what the art of the possible is around dentistry, which takes us beyond it's too difficult. And I kind of think there's a really good example of some creative thinking within this around what might we do with dentistry. Not, kind of able to be reproduced everywhere, but I think it starts from a different place around dentistry, which I think is probably not what we've done so far. So Des, James, then Jane. I haven't forgotten you, Jane. You're still on the list.
Be really quick. Thank you for the presentation. As a relative newcomer, seeing it all pulled together is really, really helpful. And to add to the list of adjectives, really exciting. I think from the lens of efficiency, productivity, everything we hear around being able to stop that bouncing around of patients all over the place, and purely from patient experience, which we were talking about earlier, this has to be one of those key answers, and getting that access sort of universally available to everybody, really a move in the right direction. So I just want to say thank you, and it's really exciting to see.
Super. Dr. Crick.
Thank you. Brilliant. As another relatively newcomer, as I'm deputising somebody today, I'm vaguely aware of the project, but I've not been anywhere near as some others. I'm really interested. When you are rolled out to talk about this, and you will be because it is brilliant, there's something about holding on to it. What I've heard is incredible integration between organisations and kind of co-production. That I think the risk is, and again, from a whole background as a public health consultant a few years ago, the story is often, well, we've got a building that's the Integrated Care Centre or the Jean Bishop Centre, and it is a brilliant building, but actually that building was 7 years in the building. It was the relationships that came alongside that took a lot longer that have led to the successes. So please, keep the work going, keep telling the story. I think it's really good to hear from a population health perspective that IND is a really blunt tool that we use, and it hides, absolutely, it hides the rurality of the rural challenges that some of our populations experience. And it's not it's your bit of the world, but actually Catterick is fairly unique, given the populations you're looking at. So I think it's really good to hear that we're using that data-driven approach to better understand our health needs and design services that sit around it. And I guess with my other hat on as a kind of prevention lead for the ICB, really good to hear that kind of multi-morbid approach, that recognition that it's not just about thinking about CVD, it's not just about thinking about the diabetes, it's actually how can we make best use of our assets in a community setting and with partners. So genuinely really exciting, great piece of work. Thank you.
Last but not least, Jane.
Yeah, thank you. I think mine builds on your point, Andrew. So this was fabulous to listen to, and I've sort of touched the outskirts of it for quite some time. But a couple of points really. One is you can never underestimate the power of passion of wanting to make a difference in the communities that you are talking about. Please don't lose that, because that's what's got you here. 10 years. I mean, I don't think that really came, the detail came through, but 10 years of vision of what you're trying to create. Absolutely brilliant, really, really, really well done. And then back to Andrew's point about the communities that use it, I think also for the workforce that works in it, the culture and the environment that you're creating by that vision and what you're trying to build will really get people to come in and use those facilities, and more importantly, people fighting to work in it probably and wanting to create something that is really unique and different. So just brilliant. Thank you.
Super. I suppose just to kind of sum up, I want to say this is what partnership can do. This is by working together, by finding something that you want to do, sheer grit, determination. It's the bold and brave I talked about before. Let's try something different, a different kind of way of working. I think this makes this really special. And there's two things. Increasingly, I talk about this these days. There's something about what we do, which is really important. What's the difference we make? But the most important bit is how we do it. And actually, it isn't really about buildings. It's about the ability to say, how do we work together? How do we do something that's going to make the biggest difference? And actually, how do we bring together different ways of working into one place? And how do we actually decide this is the thing that actually probably will be the biggest change in terms of both clinical and prevention in a place that has something. And actually, it isn't really about a building. It's about the work that you've kind of done together. And you've talked about people through. So there is so much here I think we can learn from as an ICB about where we're going to go next. I can sense that the heads around the table are now buzzing about what we could do with something similar. It actually isn't about buildings because there is no money, but actually we don't need money to do this. We just need the partnership and the willingness to do it. So I am immensely grateful for everything you do.
Thank you very much.
Thank you. We have a very, very safe journey back.
Thank you.
Chair, can we get the presentation set?
Yeah, we'll get the presentation round, and I'm looking forward, Lisa, to the invitation. I've already picked a tie. I'm not presuming, I've already picked a tie.
Thank you.
Thank you. So slightly late, Anya, to do your piece. So I'm proposing that at this point, if anybody needs to go and use the facilities, please just go and do that. Please don't tell us where you're going or your hand up because you're all adults. We'll go through your presentation. So we'll forego the break at the moment. I didn't want to kind of cut off the sudden the wave of this side of the table suddenly woke up.
Sorry.
So should we just take 2 minutes for people just to go and use the facilities? Yeah, because you're all going. So there'll be a queue. But
Who wants to listen to any?
We have been saying.
think we just had one choice. It was coffee or tea. There wasn't an opportunity to have anything properly. I'm going to go and give them a chair stand. It's the director of Winter. Okay, Anya, over to you. So voice and lived experience. You're going to give something around insights.
Yes, thank you, Chair. I'll try and move through this quite quickly to get us some time back. You've got the deck, so hopefully you've had a chance to read through, but just to set some context, and then we've got a short film at the end. So as we've discussed actually many times at board, we are seeing attendances to our urgent care services rising dramatically. So we really wanted to get a little bit more underneath that to understand what is driving some of that demand. And particularly, colleagues may remember there was a little bit in the press before the summer actually, particularly pulling out Hull and the levels of attendances from very young children in some of our urgent care services. And in preparation for winter, we also wanted to use data and insight to think really about some of the actions we may need to take and to think about our engagement and communications approach for winter. So this was pulled together for that purpose, but we thought it would be really helpful, given the interest from previous conversations with the board, to just explore it in a little bit more detail. So as I've said, we know that demand for urgent care is rising, and that is consistent across all our places. And as I've touched on, we are seeing particularly high rates of attendances in under 18s, particularly in the 0 to 10 age group, particularly for conditions such as upper and lower respiratory illnesses. If you want to go to the slide in your pack that is around the key themes, it's on the screen if helpful, but you can see in the further detail that's in the pack some of the points of evidence, but this just summarises some of the key themes, and I'll just unpack some of those a little bit more. So what we are finding as a common issue, particularly when speaking to patients that are in some of our urgent care, so that's either in A&E or in our urgent treatment centres, that in essence don't need to be there. They could have accessed another service. The primary reason is their real or perceived difficulty in accessing general practice. So if we just unpick that a little bit further, we know that from the evidence that we've got that about 1/3 of people that are attending urgent care services could have been treated in non-urgent care services. That equates to thousands in our system every month. So the size of the prize here is significant if we were able to move some of those people to the right service. And of course, their experience may also be better, particularly in terms of thinking about waiting times. Over 65% from the evidence base that we've got, so that's over 2/3, accessed a UTC instead of a GP. And again, when you unpack some of that, they're either real issues or perceived issues. So many people were telling us that they were unable to get a GP appointment, but also we had high numbers of people where they didn't try because their perception was that they wouldn't be able to get an appointment. And there were some nuances within that. So as an example, later in the day, so if you've picked little Johnny up from school and he's got a high temperature, there's an automatic sense of, well, it's not 8 o'clock in the morning, so I'm not going to be able to get a GP appointment. And then obviously, as you get later in the day, the perception is the only place that is open is one of our urgent care services. So we very much saw that playing out from the qualitative insight that we were able to get. I must stress, and we come on to it a little bit later, and of course we've had conversations at board, is that positive patient experiences are being received, and we know that we have more GP appointments available than at any time. But there's something for us to think about here, that the answer may not be more GP appointments per se in being able to square this circle in any way. There's also that point, which is a completely understandable point, that if somebody feels that their symptoms are urgent, they don't want to be waiting potentially 2 weeks for a GP appointment. So there is also that self-selection, if you like, of service, that somebody doesn't want to wait, they don't feel it appropriate to wait, and therefore they are going straight to an urgent service. Just unpacking a little bit more around the attendance by children and young people, and of course it's primarily parents that are taking, they're not going on their own. The primary reason there is for reassurance around symptoms. This is from the qualitative insight, and particularly first-time parents or those living in some of our more deprived communities, and particularly if they're closer to a hospital, are more likely to take them directly to urgent care because they just want that reassurance. They maybe don't have the network around them, they don't have the family structure around them to be able to offer that support. And we are wanting to further explore, because there's a sense that there may be a link between a lower uptake of childhood vaccination and an increased attendance from that cohort around respiratory issues. And again, when we explore that a little bit more, some of the reasons that vaccination rates have dropped, again, goes back to this sort of bit of a vicious circle, if you like, where we are getting some feedback from parents and carers saying that it's difficult for them to book appointments. Some concerns from parts of our community not understanding how you access vaccinations and the sense that you might have to pay for the vaccinations. And of course, a general vaccine hesitancy and a perceived lack of credible information about vaccines. So there are a number of issues at play here. And you can see in the pack that it unpacks that just a little bit further. I will just go back to that there are green shoots of positive experiences. So of course, similar to what we heard with Catterick, you know, this is a bit of an oil tanker. It's not something that we can change overnight. It's going to take time. But we do know that patient experience in primary care is ranked really highly for Humber and North Yorkshire. So there is a lot to build on. And as I've touched on, we know we're offering a lot more appointments. But again, there's just something to think about in how we're sort of triangulating some of this in some ways. I did just want to touch on, and again, taking colleagues back to probably around this time last year when we were presenting feedback from NHS 111, because of course, what the public also tell us is they want one point of access. Now, NHS 111 is a really good initial point of access, point of triage. So we were doing a lot of work with that insight to try and encourage people, instead of going straight to the door of ED or a UTC, to actually contact NHS 111 first. And that's been a key focus of communications and engagement activity over the last year. We are starting to pick up from the ongoing engagement that we're doing, much more conversations where people have actually used 111 and they've had a positive experience, and particularly from people that have perhaps used it a number of years ago, haven't had a positive experience, but their experience has now been more different. And much more positive. So again, we're picking up the sense that there is opportunity to perhaps shift some of this demand around the system, but I think it's helpful to bring it to the board's attention for how we think about some of this in the context of our future commissioning approach, and of course with the 10-year plan. So I'll just end on a patient video, if that's okay, and we've just got a very brief story from Ray up in North Yorkshire, again building on Catterick, who wanted to just share his positive experience of having
Thank you, Ray. Yes.
Oh, that's my VP, isn't it?
Yeah.
Thank you, Chair. That's
It's about a mile from where I live, where it's yeah.
Is that an interest you're declaring there?
Yeah,
Dr. Hill?
I
So,
don't know him.
so I mean, I kind of think your voice of experience is always very valuable, Anya, because it kind of reminds us, I think, that at the heart of everything we do, it's about people, it's about patients. And I kind of think there is something around, the 10-year plan talks about really improving patient experience and outcomes. And I think there's something to think about. You know, we've had a couple of conversations today where we talked about neighbourhood health. But we haven't talked about how do we explain neighbourhood health as a concept to our populations who are so used to using primary care in the way they use it today and kind of turning up at A&E. So there is an opportunity, I think, to kind of start a conversation which is about delivering services differently. And actually, unless we have that conversation with people who are going to use those services, we end up wondering why people are not turning up at our buildings and behaving in the way that we thought they would behave. So there is something around that which talks about, you know, we know that our patch has increasingly complex patients who need services. Actually, what those services are and where they're located is the bit that I think we have a permission to change when we move towards operating as a strategic commissioning organisation. So I think that there's something to pick up, not losing sight of the wider kind of comms piece that sits around a whole new way of working. Michelle, and then Sean, and then Alison. Oh, down the steps. I'm going to go. I'm going in order down here. I'm going to go Stuart, Sean, and Alison after we've gone to Michelle C.
Thanks. Just to note that we could probably do an equally positive story about the Healthy Together website, which Anya's team and ours are working on in terms of support for children. And because one of the choices is not 111, but the Healthy Together website. And it's a repository of clinical information that our own clinicians develop. And what you can't always tell in the data because of the clicks is the way that the professionals out there use it, print off information, give it to families and individuals that give them confidence. And you're right, the confidence piece and the reassurance piece does drive some of the families' response to turning up at A&E. And I think that is something to do with community support and the Rattan family, which doesn't exist anymore, where your granny would have told you it's fine. I think that's important. But also to note the Family Hub initiatives that are going on too will really support that reassurance piece and that support of communities.
I think there's a lot of this stuff there already. We're just not lining it up in the right way. Stuart.
I was going to follow up on the similar point, really. So the after school or possibly after work type care that's on offer from GPs, if you want to meet a person, do most of our GPs operate evening shifts so as to cope with school children and adults? Do we know?
Variable, I would say, and there's it goes back to also the point about the reality and the perception. So there's the fact that it's variable.
I wonder if we can take the population you just sampled, because the sample came from wherever it came from, and marry it up to that kind of data. So there is or isn't availability of evening sessions.
The challenge is almost always that you can't book evening sessions on the day. So even where extended access exists, and it was mentioned in the slides, extended access in the majority of circumstances, there are some planned changes for winter pressures that have been offered to practices and PCNs. But most extended access is routine, pre-bookable. And you also can't really police who gets it. So you still might have lots of retired people who are busy out.
To which I understand the answer is to keep a block of time available.
Yes, and I think part of the issue then is how people get into those. But at the moment, the biggest issue that most people have, patients and GP surgeries, is that their services finish at 6 or 6:30.
Yeah.
And then actually there's often a peak of activity at the 4 o'clock sort of finishing work. And it's sometimes to do with kids who come home from school not very well. It's also when you've suddenly got, extra childcare available. So the child that you've been holding on to all day on your own, somebody else comes home from work, you can therefore take the child.
I guess we can agree that between about 4 and maybe 10 o'clock at night, there's likely to be a bulge of potential activity.
Definitely.
Which we're probably not, which is why it's ending up, as you basically pointing out. So the answer must be to do something about availability.
Possibly, or the Royal Commission on the NHS in 1975 said, put services where patients are, don't always tell patients they're in the wrong place. So it may be that actually what we're seeing, a pattern, this has been going on clearly for longer than just this survey, that actually what it may be is that a UTC is an entirely appropriate service for people to go to that might run till 10 o'clock at night. We just need to staff it and fund it appropriately and integrate it with things like out-of-hours GP, in-hours GP and that kind of stuff.
Look, I suppose it depends where you want your patients to naturally end up most of the time. And if you want to drag them into a hospital, then the EMTC type environment.
I think, Stuart, I understand the thinking behind the point, but what we're talking about is then multiple practices that might see one or two, as opposed to a UTC that will see the collection. And if we're thinking about resource utilisation, is it the best use of resource to actually have that provision in every GP in case it happens to be a child of that practice that's needing the appointment? And actually, the resource utilisation in terms of volume is probably appropriate at UTCs. You know, your point about put the services where people go, it's a bit similar really across all ED things. Actually, about, you know, there was a push many years ago, let's have GPs in EDs, because actually patients know how to get to ED. It's always open. And actually, rather than telling them they're in the wrong place, actually, can we actually provide what they need at the time that they present? But again, with resource utilisation in mind.
And I suppose I'd challenge back and say the opportunity that we might have through neighbourhood health starts to unpick some of this stuff as well, doesn't it? It starts.
Yes, I know I'm jumping in others, but also it is worth remembering that most A&E departments in particular, and to a degree, but less so UTCs, are in areas that are often the most challenged in terms of GP numbers. And you know, they're often urban, inner city, socioeconomic deprivation, health inequality, all of that stuff. And therefore people vote with their feet. And, you know, because actually there probably is a link in some circumstances, not always, between those practices that have the biggest performance challenges and low GP numbers and so on, and the fact that they're in the same neighbourhoods as the A&E department. So people just go where they know the lights are going to be on.
So we'll have a chance to pick up some of the performance stuff, I think, when we get into the next item. So I'm going to take Alison, Sean and Michelle, and I'm going to move us on to finance and performance.
Just as you do that, I'm just a text from Simon Worthington saying he's struggling to dial in.
Right, so we may have a little bit of time then. We may have a little bit more time. I'm sorry you're struggling, but let's monitor it.
I'll let you know.
Yeah, no, that's good. That's good. Thank you. Thank you. Alison.
I guess it's, for me, it's a bit of the so what question. I think this is a really helpful report, and at risk of trying to seek a solution without properly understanding the problem, I think we are at risk of a little bit. So I guess there is something about understanding, you know, it's a really powerful statement to say there are thousands of people a month that access A&E and other services that are not structured in the way to receive them. And I guess my question is around our kind of strategic and structural intentions and ambitions as a system to be able to understand this and understand how this is not one person's problem to solve. So I think whilst we're having the conversation here, I guess my sort of question and challenge back into the space is, so what? So what does this mean as a system, and either the ICB in terms of convening that conversation, but it seems like the whole system needs to understand the problem. The whole system needs to understand that probably they need to contribute to understanding the problem before we start to seek solutions, because I still get a sense of, I'm not sure, you've given us some really good rationale, but I think how we understand that as a system and our role in it is really important. So I guess it's, for me, it's the so what and what we're going to do.
Yeah, and I think that's a really good point. I think it is the bit where as a board we need to be equally good at describing a solution as we are at describing a problem.
Yes.
I think we describe problems very well. I think the bit where the energy needs to be is what is it that we need to do differently. And actually, I think this is more than there's just acute, isn't it? This is more than just emergency care. It's about everything else that kind of contributes to that. It's about, you know, where people are choosing to go and not go. actually the opportunities we have to think about what we put around this. I think that's right. So we'll come back onto that one. So I'm going to take Sean, then Michelle, and then Andrew. I'm going to sneak you in, Andrew. Sean.
Andrew may want to pick up something now about saying fairness, but first of all, Les Ray in terms of that video, it's fantastic. So I think it's the first thing to say, and I think just picking up on comment that both Simon and Alison made there, I think there are a number of diverse factors and influences to where people access services and why. It's confidence, perception, rather than the reality of where to go, when, and for what. The use of 111 is often something that's less understood and recognised, and clearly Ray's experience is an illustration where that works pretty well. To transport and access is already mentioned, and opening hours, sort of things. And of course, we've got a range of things that over the years have evolved, depending on the nature and severity. Obviously, pharmacy access has been encouraged, primary care, UTCs, SDEC, and CD for serious cases. I brought something to board a while ago about the demand for services, and in particular, what was quite striking amongst other things at the time was the significant growth in demand at the UTC at whole, which is probably what you want to talk about, I'm sure. And that was partly to do with the fact that we relocated that from where before on Story Street, co-located it in the context of the national co-location direction travel. And demand has ballooned massively as a consequence of that. We've extended the hours. And as a consequence of that, some of the performance around turning people around 4 hours has been adversely affected because of the demand that's been massively changing. I think part of that is to do with the very issues that you touched on, Simon, around people who use it. It's in the middle of Hull, it's recognisable, etc., and easy to get to. And then the other thing to bear in mind is attendances versus admissions, which I'll come on to talk about later in terms of where we currently are. But I think part of this is, at the moment, we've got to recognise that we've got to do some work with what we've got. But our role in the future is about how are we going to commission this in a different way from a UEC commission service.
So, and actually, how are we going to use the intelligence that we have in order to ensure that the commissioning is strategic commissioning and intelligent commissioning? That's the really key bit, which I think is some of the so what question. So actually, this stuff moves from being interesting to incredibly useful, and I think that's the cornerstone of what we do. Michelle, and then we're going to come to you, Andrew.
No, just a quick part. One, absolutely great presentation. I think it's a really important report, and actually just solidifies some of the things we've already seen. Picking up Alison's point, it is a bit really so what, and I do think from an ICB board perspective, it is about how do we shape that strategic landscape and commissioning to be different and to work differently in the future, and to work with providers, because we have a lot of that detail in relationship to demand. We also have to work more collectively with the public on expectations versus demands, etc. But also picking up that whole system approach, because if we have an effect in one area and we do something in relationship to a service in one area, it will have a ripple in another. For example, one thing that we work really closely with our local authorities with this, because if they do something over here, it will have an effect on us over there and vice versa. So I think it's understanding that strategic vision and content, not just from a health point of view, but from a local authority, social care point of view, education point of view. And then third, just an observation really, just to say that one of the things you need to work with is obviously the registered bodies. And one of the things that we're doing from an organisational point of view, picking up the vaccination issue, is we asked nationally a little bit of water to go under a small bridge, but within there is to get our health visitors to do vaccinations, which will be a first in the country, because we've got health visitors that have got that skills and ability to do that. And actually there's a bit of an appetite to do that, especially given some of the low vaccination rates in some of the areas that they visit, particularly in Hull. So we'll be looking at doing that. So they're more later, but that will be a national first. And we've also had a visit from number 10 around the 2-year checks as well. But again, that will be something that we're looking at. But so there are different ways. I think what I'm saying about that example is about using the experience that we've got with the clinicians to the max and not just putting them into little silos. We de-skill them.
And I think that's exactly right. And I think about some of the work we did last year about working through voluntary sector groups and organisations, trusted organisations, where they had cohorts of people who were being, the access is different if you're kind of going outreach in organisations to give vaccinations rather than expecting people to come into primary care. And I think we don't need to lose sight of, we've got a number of different ways to do this. we just need to kind of commit to some of this is very different in terms of how we deliver it. So I'm going to come to you finally, Andrew, in terms of this, and I suspect you're going to talk about the co-location of the UEC next to A&E.
Yes, yeah. Well, I can. I just it's more once when when you've sat somewhere for a long time, and this is brilliant. But to be really honest, over the last 25 years, it's that if you went to the staff and asked them exactly, they'd tell you this 15 years ago, 20 years ago, exactly the same. 10 years ago, 5 years ago, exactly the same. It doesn't. That is exactly it, and that sums it up perfectly. The point being is there's lots of other things behind the back of it in terms of I don't think it's just about immunisations. I can't understand why officers don't vaccinate in kids' homes anyway. We used to. So it's especially mums with 6 kids, no transport, nothing. I think it's a travesty. The other thing being is that as a health visitor as well, that is a travesty. And I actually think that there are some opportunities here, but the vaccination stuff is only the tip of the iceberg, because the people that we see in the one in Hull have multiple problems, and the kids are not just about the fact they might not have had the back. It's about the house. They're sleeping on the floor. They don't have a bed. They don't have any covers. They don't get. They get one meal a day. This is what we're talking about. This is a fundamental crux, right, of the NHS and why we're not fixed at the moment, right? Is that people in the wrong place at the wrong time, right? And it's right. How long we sat here and listened to it. So my view was, when we listened to it, it was exactly the same as Alice, by the way. And I did want to say it is, so what the heck are we going to do about it? Because I'm fed up. Because I provide all these services, and I'm the biggest, currently now, UTC provider. I'm getting kicked because of demand and my performance going down. But I will say, people will come because we see them in 4 hours. Yeah. You don't sit for 15. You don't sit for 12. Where would you go?
You're not waiting 2 weeks.
Where would you go? Where would you go if you haven't got anything and you're a young mum, 18, with your little kid? No parents, nothing, living in the middle of Hull, where would you go? Yeah. I'd go A&E. Sorry, I'll go UTC. That's just life. I'm protecting my kid. Let's not forget it. These people this is what about. It's about protection. And it's about being concerned. And we've just stripped away so many layers of things that protected these people. We shouldn't be assured. We should be aware that this is just what are the solutions to this problem we've created? Really, because I think that's the bit that people really do need, and the population need it, because they're not getting any help here. Not what I see. But, I know it's public, but I don't care. We should get it sorted. So as a strategic commissioner, can I just say, if I'm not here, right, will you sort this out, please?
Thanks very much for that.
It's the one thing you could do, because you'll sort out every other problem, I think. I think we'll have a cascade. If we can sort this out, we'll have a cascade of improvement.
I'm going to bring James in. I do think some of this starts to kind of form what those strategic commissioning intentions are going to be for a new organisation. I kind of think that's where we head.
Just to add to that, though, so it's more than the strategic commissioning intentions for health. It's got to be with our department to address all of those background issues.
Housing,
it's not going to change overnight, but I do think we need to start looking at this properly from, as you've articulated, the patient perspective, the family's perspective in terms of what they can access as and when they need it, and that's that's got to be our response.
And that's potentially that wider kind of partnership that we're kind of talking about.
We've still got services at 5 days, health visit, 7 days a week.
Exactly.
Nobody turns anything off anymore, do they? It's like it's got to change, and
exactly
that's going to be challenging.
Yeah. But an opportunity. James, the final words.
Thank you. I think I agree with everything that everybody said. But I guess from a healthcare, public health perspective, I would probably just suggest exercising some caution, because what we're talking about is demand and want, and not necessarily clinical need. So the fact that the UTC is brilliant and it turns people around in 4 hours, and patients might have to wait 2 weeks, well, actually, it might be clinically appropriate to wait 2 weeks. The problem is the challenge, and certainly it's been my experience for all my GP career. The person who decides that something's an emergency at the point they decide it's an emergency or is urgent is the patient, who doesn't have any medical training, who doesn't have a nurse sat next to him, who isn't a doctor. it's really easy as a health service for us to turn around and say, you didn't need to be here after you've been assessed by somebody with a medical degree, you've done an ECG, you've got a blood test. And I guess it's how there's something from population perspective, how we manage all of that.
We have to be careful about how it is about managing expectations, isn't it? It is
communicating.
Yeah. I think that's true. So I think we're going to come back and revisit this. And I can think we're having a conversation at the next board, which is about the wider opportunities around strategic commissioning. But I do think this is clearly a massive priority. But actually, this is the bit the NHS cannot solve on its own. This is the bit that saves. And I think it's been articulated really well around. This is around the complexity of people's conditions in a range of different responsibilities across organisations that actually I'm keen that we don't lose when we move towards, because actually as a strategic commissioning organisation, to be really effective, you still have to have all that connection that sits around it. You can't do that in a NHS bubble. Okay, do we know, is Simon with us? Have you heard anything?
Emma's contacted him, I think.
I've emailed him, but
right.
Not.
All right, let's go on through it. So we were going to be joined, and hopefully still will be, by Simon Worthington, one of our retained members, who is now chairing your finance, performance, and contracting, as it is now, committee does. So we've asked Simon to dial into the public meetings when we're doing the update around that, just I suppose to offer additional assurance on behalf of the committee if we need to. And I'm also conscious, Des and Sean, you're heavily involved in this next section. I think this is about the headlines. I think we can have a more detailed discussion within part two, because I don't want you to do the presentation twice. So I think this is about giving us the overview now for us to receive, digest, and then I think we have a different discussion when we get to part two, rather than making you do the presentation again, which would be entertaining but probably quite tiresome for you. So Des, are you kicking off? Or is Sean kicking off?
The cadence of the report starts us with the performance.
So let's start with Sean.
Do you want me just to say a little bit about what we're trying to do with the report?
Yes.
From the Finance Committee point of view.
That would be really helpful. And then over to you, Sean.
So,
and I think there's some slides. I think Emma's getting some slides.
Thank you. The conversations we're having at Finance Committee are really around how do we bring together the reporting of the activity, the workforce and the finance position in a way that we can coherently tell the story of what is going on in terms of the individual parts, but then how that comes together. And so part of that discussion is how we bring that together in one place, which is the performance report. And I think what's been missing previously is the workforce and the finance bits of that information, having it all in one place. So this is just a first stab, and we absolutely acknowledge it is a first stab, so it will be an evolving process of trying to bring that triangulation piece together. So I believe it was a couple of months ago now we integrated the workforce reporting, and now we brought the finance side in as well. And so it's a new style of looking at the data that we'll be developing to make sure that we are bringing the right messages, but most importantly so that we can adequately describe that relationship with things like the pay efficiency shortfall that is part of the narrative of the driving the overspend in pay alongside increasing whole-time equivalents, and what is the problem we're actually trying to solve, and is that activity related or is something else going on? So that's what we're trying to do with bringing it together as an integrated report, but it will be under development.
Yeah, and I think that's really helpful. I think it answers some of the questions I think that we were talking about earlier, doesn't it? It's it's finding a way in which to tell the story rather than having different bits of the story sitting in different places, which is where we've been before. So we're going to move on to, you've done a big build up. So let's.
Yeah. This is the detailed slides that go with that. I'm not proposing for the reasons that you've outlined to go through it in detail, but I probably just want to draw attention to one or two, if that's okay. So in headline terms, mindful of your steer and obviously time, this is the month 3 position for the majority of metrics, so quarter way through the financial year. We have got month 4 information in here for. You're kicking me for a reason, Alton.
No. Something I said. How's reacting to the triangulation? She's not liking it. She's throwing herself backwards.
Month 4 for UEC and finance, just to draw attention.
So it's quite historic here. I suppose the context is this is quite historic looking back.
Yeah. So in headline terms, on the UEC position, July has showed an improvement compared to the previous month, positively, although we've still got some areas where we're slightly behind the plan that we sent, even though notably in Huff and York and Scarborough, their 4-hour and their 12-hour department performance has moved on positively for the July period. On plan care, on elective, we're largely on track across the 18 weeks, 52-week wait and total waiting list, albeit the exception to there is York and Scarborough's waiting list where they're recording that more effectively than was the case. I flagged that at a previous board meeting. That's still the case. Diagnostics and cancer are two areas where for several months now we have got a challenge position, and you'll recall at your last meeting you asked for a cancer deep dive that's come into the next board meeting, and there's also a deep dive being requested from both the ICB Exec and Finance and Contracting Committee around diagnostics, so we're working on that as well. What we have done is there's a whole series of actions going in place around the cancer position, including the ICB has seconded the Deputy Director of the Cancer Alliance into Humber Health Partnership to help with the most challenged areas in terms of additional capacity to help. That's just to draw the board's attention to that as a proactive illustration of what we are doing in a hands-on way to help our providers. Primary care remains largely a positive position in terms of patient experience, and of course there's a series of visits going on over the next few weeks around performance, access and other factors as part of the LES review, so we'll be able to get some more richer intelligence to draw into that. We've got some ongoing challenges around dental and the need to put in some additional capacity around urgent care, which is flagged in the report. On mental health, we've got 3 out of the 4 measures that are on track. Access to children and people is the exception to that, but that's a real positive position from where we were. I'll ask Des to draw attention to the finance, but can we just flick to the slide that shows the rankings, Emma, please, if that's okay? Again, in the spirit of the aforementioned league tables.
Making your colour palette.
So yeah, maybe it's in the separate part later. We'll come back to that later. So Des will come back to the finance position, but in summary, Chair, from a performance point of view, cancer diagnostics and despite some improvement, UEC remain our areas of challenge. Mental health and primary care remain areas of positive performance in headline terms. But I'll ask Des just to talk about that.
So before we move to that, so effectively some green shoots, and I would really welcome, and I think the board would welcome. I know we're doing the deep diving on cancer next month. I do think we need to schedule in the one around diagnostics. So my head was already in we need to have a full conversation around diagnostics. So I'm pleased that I'm reassured by the fact that that's been identified.
Absolutely, and within that, are we optimising the additional community diagnostics centre we brought online, albeit we've obviously had some delays with some of our sites.
We just need to talk to Sasha and the governance team about just making sure that's logged in the plan for the board. But I think that would be really welcome. Des, you're going to talk about money.
Thank you. So I'm referring to page 22 of the pack that we're looking at the moment, and this relates to month 4 performance. Just to be really clear, we don't yet have concluded position on month 5, so month 4 is the latest available information. Because it's a new report, just so that everybody knows what they're looking at, we've included on here the 4 metrics that NHSE are looking at in determining the criteria, or the criteria they're using to determine the continuation of deficit support funding. So 4 of our acute providers are in receipt of deficit support funding as in their plan, as is the ICB. We will keep an eye on whether these are the metrics, these are the only metrics, or whether we need to expand this going forward. As I said earlier, this is a starter, but the 4 metrics, just to remind everybody, are the absolute variance to plan, the variance on the efficiency delivery, the pay variance, and the net unmitigated risk compared to what was put in the original plan. So those are 4 of the blocks that you can see on there. And just as a reminder to everybody, under the current regime, NHSE will withhold deficit support funding if they haven't got significant assurance around the deliverability of the plan and the recovery of the year-to-date position. So far we've had Q1 and Q2 deficit support funding confirmed, but the next decision point will be month 5. So the other thing to note also is that if we end up not achieving the financial position this year in 25-26, then any deficit support funding we do receive this year has to be repaid in full in the following financial year. So it becomes a increasingly more difficult task to close the gaps down. So it's just important that we keep an eye on what's happening with these metrics. The fifth one I've included there is cash, because that is obviously of a particular concern when we're running a deficit plan, and just keeping an eye on how that tracks against our planned position. So in terms of the data that's included in this report, the absolute variance to plan in month 4, we had a £14 million planned deficit. We posted a £19 million deficit as a system. So we were £5 million adverse variance to plan. The deficits largely sit with almost entirely sit with the providers, the acute providers, that is, partially offset by a surplus in Humber Health. So we're focusing in our recovery actions on those acute providers for the moment. A lot of that hinges around efficiency shortfall. So there's a connection between that year-to-date position and the efficiency shortfall in the second metric. And there's various sort of pay pressures in 2 of our organisations as well, to align with challenges they have in those organisations. The ICB did, within that number, post a small adverse variance, was 53k within month 4. Largely, we've got 2 overspending programs, which is acute and mental health, mostly around independent sector and right to choose, offset by some large underspends in some of the other programs. So it's balancing itself out at the moment, but obviously we're keeping a watching brief, and we'll talk a bit later in the second part about the recovery actions and what we're doing there. In terms of the efficiency, the system efficiencies are 15.5 million behind plan. There was a high level of unidentified efficiencies at the start of the year. And whilst we've got most of those identified now, there's a phasing issue with some of it, because it was unidentified at the beginning of the year, but they assumed it would start going sooner than the plans that they've identified. So we've got a little bit of a delay in getting started, and then we have some schemes that aren't achieving, and we're working with our providers to look at recovery actions. And within that number, the ICB had £5 million of shortfall, but we are expecting that to improve in month 5 as we move through, assuring our schemes. All of our shortfall is pretty much in the independent sector schemes that we put forward. And just as a reminder on plan conditions, so NHSC region gave us a few plan conditions. One was to have 0 unidentified schemes by the end of Q1, and the other was to have no high-risk schemes. Those 2, there was a third one which we did meet, and that was around recurrent and non-recurrent, but we haven't managed to have all the schemes identified. We've got one provider that's still got 11 million of the 57 that was originally in the plan, so we're still working through that. And in terms of the high risk, whilst it's halved from 134 to 70, again, one provider's got a huge amount of over 60 million in there, and the ICB has 7 million in there that's related to the transition, as we spoke about earlier. So that's the position for those. The risk, for the first 3 months, we saw an improving unmitigated risk position as we were moving through our budget. Our plan was to have, we had 89 million that had dropped to 73 million in month 3, but it's moved to 94 million in month 4. There were a few assumptions that went in with providers. We've been working with them, and we're expecting that to come back down again in month 5. So that's been contained. And then finally, just on the cash, it is better than we planned at the moment. There's a degree of capital slippage sitting behind that, and we just need to keep an eye on that situation. So we've had signed off recovery plans from all the organisations that have adverse variances at the moment, and those have been signed off by their boards, detailing the actions they're taking, and we're just working through, by way of assurance to NHSC and region, how we assure them that we have a grip on the situation, and whilst it's adverse to plan, the recovery actions, and we're tracking each month how those recovery actions are playing through, and we are expecting to see an improved position from what we can gather for month 5, but we'll be waiting to see that come out this week.
And we can pick up on this in more detail in part 2. I think this is just for us to note at this stage, and we can pick up that conversation. I suppose just to note as well, Jane, the workforce page that's kind of part of this now as well, that triangulation including the workforce piece, it feels as though that in some ways has been a missing link in some of this, because actually it's giving us a much more rounded position of understanding the organisation in terms of finance performance, but also I think crucially the workforce. I think the workforce pressure cannot be underestimated at this point in time.
No, that's true. You've had the workforce information for some time in the report, but not necessarily the triangulation piece.
The triangulation piece. I think that is the bit that we were missing before. So we will come on to this. So that is just for us to kind of note that position in terms of performance and that position in terms of finance, and we will have that conversation when we move to the next section. Okay, so we're noting that and we've received that information. So that dovetails us, I think, Sean, into winter planning. And we touched on this last time, didn't we, in terms of course, in this room, for anybody who's watching this, in this room, if people don't move for a while, the lights go out. That people's brains are moving, but the ceiling isn't registering that at this stage. So it requires them to leap across the room there. So winter planning. So we talked about this last time, didn't we, in terms of winter planning, Sean? And we talked about the checklist, and we kind of signalled this would be coming back to the board today to see where we were at with. And then I think there's a set of actions in here in terms of sharing that initial bit, and then I think delegating to me and Teresa the authority to sign off the final checklist and plan on behalf of the board.
That's correct, Chair. Yeah, brought the requirements for winter to the last board as a precursor to bringing this back today. In terms of the timing, the construction of these documents took place at the very end of August and early part of September, that coincided with an HNY winter testing event on the 1st of September, that then preceded a regional test event in York on the 3rd of September. So there is some work to do on this post this coming to board because of that timing issue in the light of those respective events. But what you've got here is a cover report, a narrative, and obviously the board checklist, which has got a couple of things that got some gaps on in the light of the position. But for here, just to bring board colleagues up to position around where we are and the content of the plan, reflection on last winter's learning, and there are a number of key areas that we need to do some further work on, some of which we've touched on already in some of our conversations. But 7-day service response, particularly around the weekend, to minimise the challenges that we experience around pressures on a Monday and Tuesday. How we respond in an appropriate, timely way to mental health patients that present in ED. The issue around paediatric demand impact on the workforce, and that links in, amongst other things, around the whole vaccination piece that was touched on earlier. I think Michelle mentioned around the letter that we received earlier this week. Last year's take-up of vaccination for a variety of different reasons that a number of colleagues will be aware of was much lower than previous years. And a surprise, we had a lot more absenteeism and a knock-on effect in terms of the impact and challenges and closed beds, and then obviously resulting cost in bringing in more bank and agency staff in terms of our workforce, which we've just touched on is something that is a challenge in relation to our workforce plan. IPC is a key factor in that in terms of supporting preventative action and minimising the spread, but also working through our processes for business continuity and critical interposition. So there's a number of areas there that need to be factored into this following the event last week. And there's also going to be some further guidance made available from NHS England around corridor care, because the Secretary of State is keen to more consistently manage and monitor that in the light of the test spaces that were brought in last year. So there's further work to do in those areas that we just shared. But as things currently stand, this is for board assurance stroke approval pending sign off by you and Teresa between now and September 30th. So we submit that checklist as set out.
And you've supplied within this the copy of the template that we have to kind of complete. There's two elements to the template, isn't there? There's the strategic one, which is the ICB, and then there's providers will then have to do there. So essentially, this is from the ICB point of view a high level assurance around our winter plan rather than huge amounts of detail which sits with providers. That's the difference between it.
Just for clarification, we don't have a role in signing off why the plan is there, but
we offer an assurance and ECB point of view around our plan, which is what this is about, which is different. And I think what you're starting to do within the checklist, I think that's been shared with the board, is I think there's a lot of narrative within the relevant pieces. Some of it still kind of needs to be worked up, doesn't it? And there's notes in the margin. But I think, what's the deadline for submission for this?
30th September.
So we've got a little bit of time with this, and I suppose we've circulated this early so that partners can kind of have a read of this. I think this is the opportunity for partners to say, hang on a minute, I'm not quite sure about this. And I think by the time we get to that stage where you and I need to then sign this off, I think it will probably not be vastly different from this, but I think we'll probably lay it in with some of the detail and the additional clarification I think you've talked about from the call. So inevitably what happens is you start to complete it and then there's a call that tells you need to think about another thing, which is always helpful, I always find. Any questions around the winter plan? Louise?
Quick comment, I mean, completely agree with obviously trying to promote vaccines with our healthcare staff, same with local government where we've got social care staff as well. Really important, and I suppose this is in the context of the messages to the public around winter warmth and seasonal health. So there's a whole other active work that really complements this, I think, in terms of helping people to access their own vaccines. It's this time of year, isn't it, where people should be getting called. So please take it up if you're watching this live stream. It is really important and helps us all through winter.
And I think there's probably quite a lot of learning from previous kind of years in terms of some of the stuff that we've done. And I think we've been, my experience in a different life in the ICB has been, we've been quite innovative around how we've joined this up with other stuff and around actually where does this sit within the local authority based plans around winter warmth and you know all that type of stuff. So I kind of think none of this is new. I think this is about how do we build on what we have already, but actually what's the opportunity to do the things that we might have done differently had we thought about it last year. And I think that's what the plan kind of captures. Anything else on the plan, or are people happy to, in its outlined state, and then to delegate to me and Teresa to do the final sign off on behalf of the board? And of course, we will share that back with the board once that. Okay, superb. Are you enjoying being director of winter, Sean?
I'm conscious that we're being live streamed, Chair, so I'll discuss that with you later. If that's okay.
It must be winter because I had boiler service yesterday, and my plumber said to me, "That's right, winter starts in September. Well done for getting it done early." And I thought,
I'm already kicking from my colleague next to me. Well, that was down to I'm not quite sure.
Yes, that's superb.
Thank
you very much indeed. Okay, so we're going to move on to the insights report. You'll be pleased to know that I'm not proposing to kind of go through all of these line by line. If you remember, part of I think our drive to increase connectivity between the board and its committees, but also to ensure there was kind of real transparency and assurance for the board in terms of what committees were doing, but also going back to that conversation we had about risk at the start of the meeting, that committees were aware of their risks and were managing and mitigating their risks. We kind of implemented the insights report. I think we may have done it too well because everybody now wants to submit an insights report, whether or not we ask for it or not, which I think is really good. So that ability to share and be interested in parts of the organisation. So you have, and I think you're just going to guide us through these, Jane. You have a collection of insights reports. So these come to public boards. So inevitably you probably get 2 insight reports per committee, depending on the committee falls. And we need to kind of get into that kind of rhythm. But all I was proposing, Jane, is that we just look at them and then just seeing if anybody had any questions around anything that's in these reports.
Yeah, I think they're fairly self-explanatory, actually, Chair, when you work through it. Some committees, as you rightly say, have had 2 meetings in that period of time. It's a format that's different but similar to what we've had previously. So the report itself just highlights what each committee is raising, and there wasn't anything to raise to the board in any of them.
And there is the opportunity through the reports to escalate to the board as well.
That's right.
In terms of, and actually there is an equal emphasis on things that we need to be proud of as well as things that we need to be worried about, which I think is really important. So the first 2 are finance, performance, and you were delivery then, but now you're contracting.
Yes, that's correct.
Super. Remuneration committee, anything you want to say on that, Mark?
No, just what it is. Happy to take any questions.
Okay, there's clearly quality in the 2 that relate to the workforce board, which is clearly down to the chairing that particular committee. Clinical and professional, you're being Nigel. Anything you want to say, Nigel? Thank you. Population health, Louise?
There's no to the annual reports published, so please read it.
Okay, mental health, learning disabilities, and autism collaborative, Michelle?
I think there's nothing to note.
Super. Primary care collaborative. So are the board happy to accept those insight and update reports from our key committees and groups?
Sorry, Chair, I'm not sure if Simon Withington managed to get on the call. Is he there?
No,
No. Okay.
I didn't know whether you wanted to say anything.
No, I was watching the big screen and I didn't see him on the big screen, so
He's texted his apologies.
no, that's fine. That's absolutely fine. And I kind of,
Thank you.
yeah, thank you. Okay.
Can I just give a comment on that? Because I think these reports are actually really useful.
Yeah, they are.
I think they're much more user friendly, and get to understand what the committee's actually doing. Easier.
Yeah. And I really do need to thank Sasha and the governance team for putting up with me going, needs to have this in. I don't like this. I don't like that. And actually, I think we've got to a place where we tested it with people and said, does this work? And I think it has worked really well, which is really good. You'll continue to get these kind of flowing through, and just to all kind of chairs of committees and executive leads. Please don't think that you can only escalate stuff to the board via this report. Actually, if there is something good or concerning that you need to share with us, then please shout and we'll get it onto the board forward plan. It's really important. Okay, so we'll move on from insights into more good news. So please come and join us. Come and join us. Sit at the table. We've got Scott and Kate here to talk about the evaluation of the Stop Smoking kind of campaign. And I kind of think